So let's start again with the GIT prompts. So today we're going to discuss the approach to each of the GIT prompt. Among the GIT, if you notice the last 3.5 years or the 4 years period, you will see these prompts are coming. Among them, we are going to discuss today the dysphagia, hematemesis or blood vomiting, melena or black tarry stool, loose motion, abdominal pain. The first 5 prompts are the triple star prompts. Before starting, may I confirm again, am I audible to everyone?
Yes.
Okay, thank you for your feedback. So the first 5 prompts are the triple star. Triple star means they have come a lot. Then there are some double star prompts. They are the constipation or tight motion, pararectal bleeding, vomiting. Then there are some one star prompts. They come very less frequently. They are jaundice, sorry, uh, then liver function test abnormalities diagnosed incidentally, approach to a space occupying lesion in the liver, and approach to a space occupying lesion in the adrenal gland. So let's start with the dysphagia first. Before starting from the GIT for the dysphagia, let me tell you something important. For every GIT prompt, don't forget to ask this question in the family history. That is, any family history of bowel cancer. Because if this comes positive, automatically in one of the differential diagnoses, the bowel cancer will come. So this is the most important family history for the GIT prompts, all the GIT prompts. So let's discuss the approach to dysphagia. So if we consider our digestive tract, it starts from the oral cavity. After starting from the inside of the oral cavity, the food gets processed by the tongue and the saliva and all that stuffs. Then it enters at the back of the oral cavity. This part is called pharynx. This pharynx is basically divided into 3 parts. One is oropharynx, one is nasopharynx, then oropharynx, and this part is called laryngopharynx. This is called nasopharynx because it lies behind the nose. This part is called oropharynx because it lies behind the oral cavity, and this is called laryngopharynx. This part is called laryngopharynx because it lies behind the larynx. So the food bolus, after the oral cavity, it enters into the oropharynx. From the oropharynx, it enters into the esophagus. Whenever the food particle comes inside the mouth, then through some nerve receptors, signals go directly into the brainstem, and that part is called medulla. It goes there by 3 nerves. They are trigeminal, glossopharyngeal, and vagus. There are some nerves there. After the signal goes there, the brainstem sends some signal, and the function of the signal is that to ensure the coordinated movement of this uvula, soft palate, then the epiglottis, and also the oropharyngeal muscle, so that the food can pass in an easy and coordinated way into the esophagus, not it enter into the nasopharynx or in the ear cavity. This is the function of this nerve signal. I'm again repeating. When the food bolus comes in contact with the oral cavity, it sends a signal to the brainstem, especially the medulla, and the brainstem sends a signal back to this part of the oral cavity, especially the soft palate, uvula, tongue, then epiglottis and oropharynx, to ensure the proper movement of the food bolus into the food pipe. So in this passage, the soft palate gets elevated, closing the way of the nasopharynx, so that the food does not comes back into the comes to the nasopharynx. It also causes coming down of the epiglottis, so that the food does not enter into the airway. So if any problem happens in this signaling pathway, automatically the soft palate will not get elevated. So there is a chance that food will come out through the nasal cavity. It is called nasal regurgitation. There is a chance that the epiglottis will not be able to close the airway. So food will have a tendency to enter into the airway, resulting in cough. Also, this soft palate and the tongue has their role in production of the voice. Whenever there is any problem in this signal or the functioning of these muscles in this part, the voice becomes impaired, resulting in nasal voice. Before discussing the dysphagia, I have discussed this pathophysiology in details because this is something important to understand. For the dysphagia, there are two types of dysphagia. One is oropharyngeal. Another one is esophageal. Oropharyngeal means there is some problem in this nerve signaling pathway or in the functioning of these muscles. So basically, all the neurological causes of dysphagia are oropharyngeal dysphagia. And esophageal dysphagia are of two types. Any question from any doctors? Okay. So why I am telling this? There are basically two types of dysphagia, that is oropharyngeal and esophageal. And from the very beginning, our job will be to differentiate them both. So how to differentiate them? Our first question should be, like, when does it occur? We may be given a case like a 35-year-old Mrs. Camellia has come to you with swallowing difficulty. We may be given some vitals there from the outside, and we'll be given instruction in the form of talk to her, examine her, and meet her concern. So after entering, after doing necessary introduction, we have to start like this. We have to ask the patient, when does this occur? Does it occur at the start or after you start swallowing? That is, when you put the food bolus into your food pipe. If it occurs at the start, then this is a case of oropharyngeal dysphagia. But if it occurs after the starting of the swallowing, that is when the patient put the food bolus into the food pipe, then this is a case of esophageal dysphagia. And these first two questions are the most important questions, and the examiner will look at you whether you are ruling out oropharyngeal from the esophageal. And this is the very basic question for any case of swallowing difficulty. The third question will be, is it to solid, liquid, or both? This has important implication. I'm going to discuss it later on. Then this is the question of welfare. Like, you are careful of the patient, that with this swallowing difficulty, how you are taking food right now, what kind of food you are taking. It may be like that the patient is unable to take food right now. So we have to ensure the nutrition of the patient. To ensure the nutrition, we have to ask this question. So these are the initial question. Support from the history, we have got that this is starting at the start. So this dysphagia is occurring at the start. So this is a case of oropharyngeal dysphagia. Right after that, we have to ask some supporting questions of oropharyngeal dysphagia. The supporting question is that we have already discussed how oropharyngeal dysphagia can present in with nasal regurgitation. So we have to ask the question of nasal regurgitation without using any jargon. Regurgitation is a jargon, so we have to ask in this way, have you noticed any food particle coming through the back of your nose? This is the question of nasal regurgitation. We have to ask, have you noticed any change in your voice? That is the nasal voice. We have to ask, have you noticed any cough on swallowing? That is due to the aspiration. We have already discussed, whenever the movement is not coordinated in a proper way, the epiglottis will not come down and close the airway. So food will come in this way, that is the airway. It will cause irritation, resulting in coughing and breathlessness. So you have to ask any cough on swallowing, any breathlessness, or choking episode on swallowing. So these are all the questions for oropharyngeal dysphagia. We have to ask this question if we get it positive from the first question, that the dysphagia occurs right at the beginning. But if the patient tells you that the dysphagia occurs after the start of the swallowing, then we have to ask these two separate questions. Whenever the dysphagia is occurring after the start of the swallowing, that is whenever he is going to swallow the food into the esophagus, that is esophageal dysphagia. In case of esophageal dysphagia, we have to ask, have you noticed any impaction of food bolus? Patient may point toward his or her chest that I feel something is stuck behind my chest. Then whenever there is any esophageal dysphagia, there can be oral regurgitation. Here it is nasal regurgitation, but in case of esophageal dysphagia, it is oral regurgitation. We have to ask this question that, have you noticed any food particle coming through the back of your mouth? This is the non-jargon term of oral regurgitation. So these are the questions for esophageal dysphagia. May I know up to this part if any doctor has any confusion or question? If it is clear, please give me a thumbs up reaction so that I can proceed forward. Dr. Satish, are you clear, doctor? Okay. Dr. Sushma, are you clear? Okay. So, right after that, we'll jump into the differential diagnosis. Let's start with the esophageal first. Suppose the patient has told you that it starts after the start of the swallowing and he feels something is stuck behind his or her chest, and he feels sometimes some food particles comes to the back of your mouth, her mouth. The next thing is we have to differentiate whether this is mechanical obstruction or due to some motility disorder. Okay, let me give you some idea what is mechanical obstruction and what is motility disorder. So this is the esophagus. Food may be obstructed or food may be face some problem in passing forward due to two types of problem. One is due to mechanical obstruction. Another is due to motility disorder. That is basically absence of peristalsis or decreased peristalsis. So if anyone is having mechanical obstruction, then it will cause esophageal dysphagia. And if the esophagus is not having enough peristalsis, that will also cause motility dysphagia. How to differentiate them both? You can remember, first we had asked, is it solid, liquid, or both? In case of mechanical dysphagia, it will be only to solid, or started with solid, but right now it is to both solid and liquid. Like the obstruction initially obstructed the large particle, but right now the obstructed has completely occluded the lumen, resulting in no passage of any food particles from solid to liquid. So it will be either solid or started with solid. Right now it is both to solid and liquid. If the patient, we have to ask, do you have any swallowing difficulty to solid or both to solid to liquid? If the patient complains that both to solid and liquid, we have to ask, did it started with solid or started with both solid and liquid? If it started with solid, now it has progressed to both solid and liquid, then it is mechanical obstruction. But from the very beginning, if it starts with solid and liquid both, then this is a case of motility disorder. Sounds clear to all? So mechanical. This is motility. So these are the two types of esophageal dysphagia.
ASD means what?
Yeah,
ASD
I'm going to discuss it in details. This is mnemonic.
Okay.
So what are the causes of mechanical dysphagia? Mechanical esophageal dysphagia. The mnemonic is APICS. And the mnemonic for motility disorder dysphagia is ASD. Let's give in detail. Here, E goes for esophageal ring. Esophageal ring means it is found in Plummer-Vinson syndrome, that esophageal way. E also goes for eosinophilic esophagitis. So this goes for E. Then P goes for pressure from outside. Suppose anyone is having any lymph node swelling around the esophagus. That lymph node is going to compress the esophagus, resulting in mechanical dysphagia. Also, if anyone has lung cancer, and the cancer and the mass of the lung cancer, if it resides around the esophageal wall, that can compress the esophagus, resulting in mechanical dysphagia. So that means pressure from outside. Another P is for pharyngeal pouch. I'm also going to discuss how to rule them out, the screening question for each of them. Just wait for some time.
Wait a minute.
So P goes for pressure from outside. This is likely due to malignancy and pharyngeal pouch. Then I goes for infection. This is basically esophagitis. This esophagitis can be due to any infection like Candida, herpes simplex virus, or cytomegalovirus, or this esophagitis can be due to bisphosphonate. Some sound is coming. Doctor, I'm just requesting if anyone's mic is on, please pause it for a while, unless you don't have any question to ask. So this is for infection. Infection means esophagitis. This esophagitis can be due to infection due to Candida, herpes simplex virus, or cytomegalovirus, or it can be due to bisphosphonate. Then C goes for cancer, and S goes for stricture. This stricture can be due to long-term jar, or due to some radiotherapy or history of caustic ingestion. Like the patient has ingested some caustic substance like some phenol or harpic, this can form stricture in long term. This can be due to any radiotherapy also. So this is the mnemonic to rule out mechanical dysphagia. Also in your real life, whenever you are going to face any patient in a hospital, you can rule out all the differential diagnoses of dysphagia based on this approach. So how to rule them out? What should be the screening question? To rule out the esophageal ring, it is found in Plummer-Vinson syndrome. That is a form of iron deficiency anemia. So we just have to ask the screening question of anemia. That is, do you think you are getting pale day by day? This is the screening question to rule out esophageal ring. Then for the eosinophilic esophagitis, patient also will have bronchial asthma and history of atopy. So we have to take history of this 2A, that do you have any bronchial asthma? We can also ask it in the past medical history, or do you have any itching or any problem in allergy? This case has come in the PACES exam. This eosinophilic esophagitis, this case came at Delhi Center. Patient was having bronchial asthma. He was also having some eczema-related problem. The diagnosis is eosinophilic esophagitis. Then P goes for pressure from outside. Pressure from outside means cancer. To rule out any cancer in the PACES exam, the mnemonic is triple L. That is loss of weight, loss of appetite, lumps and bumps in the body. I'm again repeating, to rule out any cancer, just remember the triple L. That is loss of weight, loss of appetite, lumps and bumps in the body. So we have ruled out the pressure from outside for any malignancy, the lung cancer or any lymph node enlargement. To rule out pharyngeal pouch, we have to ask about the bad odor, because patient will have some halitosis. We just have to ask, sorry to ask this personal question, do you feel any bad smell. But up to now, this pharyngeal pouch has not been given in the PACES exam.
Is there any age specification, like old age people or anything?
Yes. Usually old age people is most likely here, this P. But I'm discussing the screening question. Once you get the screening question positive, then you have to confirm it by asking all the other features. Pharyngeal pouch is available in the old age, but up to now, this case has not come in any center. Is it clear, doctor?
Yes.
Okay, thanks for asking the question. If anyone have any kind of question, please feel free to ask. Then I goes for infection, that is for esophagitis. In case of esophagitis, patient will have odynophagia, that is painful swallowing. So we just have to ask, do you have any pain while swallowing? And that's all to get our diagnosis. If there is any pain in swallowing, look at the personal history. Whether the patient has any casual sexual conduct, because herpes simplex virus and cytomegalovirus is most likely to have in case of HIV. Whether the patient is taking any steroid inhaler that can result in candida esophagitis. Look at the drug history, whether the patient taking any bisphosphonate that can cause painful esophagitis, that is odynophagia. So that's all for infection or esophagitis. Then C goes for cancer, that is esophageal cancer. We have already discussed. Can anyone mention it for me? How to rule out any cancer for any case? Any doctor?
Weight loss, loss
Then?
of appetite, lump and bump.
Yes, same for this. Then come to the stricture. In case of stricture, we have to ask, do you have any long-term heartburn? What happens in case of GERD? Patient has long-term heartburn, but suddenly his symptoms get improved. That right now she is not feeling any heartburn. The reason is that she has already developed the stricture. So no reflux is going to happen right now. That's why her symptoms has improved. But she has developed some dysphagia also. This case has come in the PACES exam. That is, patient is having long-term heartburn or chest burn, and that is resulting in stricture. If the patient complains of any past medical history of breast cancer, which needed some radiotherapy, then right now it can also result in esophageal stricture. But this case has not come up to now in the PACES exam. But you can keep it in mind. If it comes, then it can easily come out. So this goes for mechanical dysphagia and all the screening question. Let me know from the doctors whether anyone has any kind of question or confusion from this epics. Okay, one doctor is clear. Should I proceed forward? The next one, ASD.
What was the question for esophageal ring?
Esophageal ring is found in case of iron deficiency anemia, resulting in Plummer-Vinson syndrome. So to rule out any case of anemia, we have to ask, do you think you are getting pale day by day? Or anyone has told you are getting pale day by day? That's all. This is the screening question. Clear, doctor?
Yes, sir.
Then the next one is motility disorder. Here, A goes for, in case of motility disorder, it will be both solid and liquid right from the beginning. Here, A goes for achalasia, S goes for systemic sclerosis, and D goes for diffuse esophageal spasm. In case of achalasia, the screening question is, let me write it, it's a long. Do you need to drink lots of water? Do you need to drink lots of water or use specific posture to push the foot down? this is the screening question of achalasia. In OST, it is written that do you need to move your body from... Sorry, sound is coming. Okay, in case of OST, it has been written that do you need to move your body from side to side to help in the process of swallowing? It was written in achalasia in OST. But I think this would be the more suitable question, because what happens in achalasia, the lower esophagus lost its peristalsis. So the patient has to drink a lot of water, and they have to keep upright to help in the swallowing. So you can just ask, do you need to drink lots of water, or use specific posture to push the food down? Because whenever the patient is going to drink a lots of water, that will create some cavitation that will help the patient to swallow. The patient will sit upright, making the neck straight, and until the food comes down, he will assume this posture of his own. So this is called achalasia. Is it clear to all? Okay. Then for systemic sclerosis, we have to ask about skin thickening. That is, do you have any skin thickening? We all know that in systemic sclerosis, patient will have skin thickening below the elbow or above the elbow. In below the elbow, it will be limited cutaneous systemic sclerosis. In case of diffuse cutaneous limited systemic sclerosis, it will be above the elbow. In our introductory session today, we have skipped a portion of rheumatological sets of questions that will cover all the rheumatological diseases. We are going to discuss it in detail in musculoskeletal session. That in case of any change in the color of finger after exposure to the cold, any joint pain, stiffness, skin thickening, difficulty in raising arm, hair fall, eye grittiness, eye redness, any mouth rash, any facial rash, any mouth sore. So these sets of questions will cover all the rheumatological diseases like the SLE, systemic sclerosis, polymyositis, dermatomyositis, all that stuff. But the screening question for systemic sclerosis is that any skin thickening. Do you have any skin thickening? For diffuse esophageal spasm, we have to ask about the chest pain. It will mimic like a myocardial infarction or acute coronary syndrome. So this is all for motility disorder. Suppose we have been given a case of systemic sclerosis with dysphagia. So in the differential diagnosis, we can mention all three of them, that it can be due to achalasia, it can be due to systemic sclerosis, it can be due to diffuse esophageal spasm. But at the same time, we have to mention the points that goes each of them. Like against this diffuse esophageal spasm, the patient is not complaining of any chest pain.
How can I differentiate like acute coronary syndrome and esophageal spasm? Okay, so diffuse spasm will have motility disorder.
ফিটে খাবা ফিটে খাবা চলো
I'm extremely sorry, my device certainly got hanged. That's why there was a sudden pause. I'm extremely sorry for that. So let's come back to the motility disorder. I think no sound came up to now. Am I audible right now, doctor? It sounds clear?
Yes, sir.
Okay. Pardon from my side as my device got hanged. So did you hear how to rule out the diffuse esophageal spasm? Do anyone have any question regarding the differential diagnosis of motility disorder?
So how can anyone differentiate diffuse esophageal spasm chest pain or acute coronary syndrome chest pain?
We have to keep it in differential. Like if in the past medical history, again the magic of past medical history comes. If in the past medical history the patient has diabetes or hypertension and he is a smoker, then we have to keep acute coronary syndrome as differential diagnosis. We have to rule it out by doing the ECG and the cardiac troponin.
And also in acute coronary syndrome, patient will not have is swallowing difficulty.
Yeah, patient will not have swallowing difficulty. But you can mention the DD of chest pain as diffuse esophageal spasm. But at the same time, you have to tell the point that goes against it, that there is no swallowing difficulty. Did you get this point, doctor?
Yes.
Okay. So in the exam, if you have been given with any motility disorder, you can mention all the three. But you have to keep the first DD as per the given case. Then you have to mention the other, but at the same time, you have to tell the point that goes against the other differential diagnosis. Like the patient can have diagnosis of achalasia, but he's not having chest pain. So after mentioning the diffuse esophageal spasm as the last differential diagnosis, you have to mention also that against that, the patient is not having any chest pain. Sounds clear to all doctors? Should I proceed forward to the oropharyngeal dysphagia now?
Yes.
Okay. So in this way, we have covered all the cases of esophageal dysphagia. Now let's come to the oropharyngeal dysphagia. Suppose the patient has replied that the dysphagia starts at the beginning and he is also having food particles coming through the back of the nose, change in the voice, that is nasal voice, cough and breathlessness or choking sensation when swallowing. Then this is a case of oropharyngeal dysphagia. This is basically that all the neurological causes of oropharyngeal dysphagia. All the neurological causes of dysphagia. To make it in mind, we have to understand this structure. So this is our brain. Pardon me for this bad diagram. This is the spinal diagram. This is the spinal cord. Then from the spinal cord, the spinal nerve arises. Here is the anterior horn cell. The spinal nerve then meets the muscle at the neuromuscular junction. And this is the muscle. So in this diagram, any pathology happening in this pathway can cause oropharyngeal dysphagia. Let me give you some example. In the brain, if the patient has any stroke, like the lateral medullary syndrome, patient can have neurological dysphagia. It can happen in case of advanced Parkinson disease or in case of multiple sclerosis. All of them are the CNS pathology. In the anterior horn cell, patient can have oropharyngeal dysphagia like the motor neuron disease. Motor neuron disease is one of the anterior horn cell disease. At the neuromuscular junction, it is the myasthenia gravis case. And this is the most important and only one case that has come up to now under the section of oropharyngeal dysphagia in the PACES exam. Then at the level of the muscle, it can lead to dermatomyositis or polymyositis. It can lead to myotonic dystrophy. So there can be multiple causes. But for the PACES exam, if you have to remember one cause, then this is myasthenia gravis. These other causes have never come up to now in the PACES exam with the prompt of dysphagia. So how to rule them out? What should be the screening question? To rule out the stroke or PD, we just have to ask. To rule out the stroke, we have to ask, do you have any weakness at any particular side of your body? To rule out the Parkinson disease, we have to ask, do you think you are getting slower day by day? To rule out the multiple sclerosis, we just have to ask any recurrent episode of weakness, because multiple sclerosis is a relapsing and remitting condition. It will have recurrent episode of affection of multiple parts of the brain. To rule out the motor neuron disease, we just have to ask the weakness. Do you have weakness at any parts of your body? And to rule out the myasthenia gravis, the screening question is, sorry, let me write it. The screening question is, do you feel any weakness that is increased at the end of the day? If it comes out to be positive, then you have to follow the rule of D. I have already discussed what is the rule of D.
Sorry, can you again repeat what question will be asked in case of MND?
Only weakness, nothing else.
Okay.
This case has never come up to now. Only myasthenia gravis has come. So this is for myasthenia gravis. To rule out the muscle pathology, we have to ask the question of proximal myopathy. That is, do you feel difficulty in combing hair or getting up from the chair? And that will cover the dermatomyositis, polymyositis, and also myotonic dystrophy. Among all the causes, again I am telling, myasthenia gravis has come up to now. No other cause has ever been given up to now in the PACES exam with the prompt of dysphagia. So let me know from the doctors whether anyone has any kind of confusion from the approach of dysphagia. And this is all for dysphagia. Please tell me, doctor, if anyone has any question from the approach to dysphagia or any of the pathophysiology. Is it clear to all? If it is clear, please give a thumbs up reaction. Okay. I've get so many thumbs up reaction, so I can proceed forward. So dysphagia is clear, and it is very much important, doctors. Please take a detailed preparation for this dysphagia approach, because this is a triple star prompt, and this has been coming for every diet. The next triple star prompt is hematemesis. So what
Sir,
should be there? Yes.
Sir, what was the mnemonic for dysphagia?
Doctor, we have discussed in detail. There are several mnemonics. For the esophageal, there are two types. One is mechanical and one is motility. How to rule them out, we have already discussed. For mechanical, it is EPICS. For motility disorder, it is AST. For oropharyngeal dysphagia, there is no mnemonic. You have to understand this diagram. That is brain, CNS. Then this is anterior horn cell. Then this is peripheral nerve. This is neuromuscular junction. And this is the muscle. Neurological dysphagia is also called oropharyngeal dysphagia. So any pathology affecting the CNS or anterior horn cell or the neuromuscular junction or the muscle can present as oropharyngeal dysphagia. Among all the causes, only the myasthenia gravis, that is pathology affecting the neuromuscular junction, is the most important one, because this is the only case that has come up to now.
Okay, sir.
Okay. So our next prompt is hematemesis. This looks so much simple, but this is one of the most important prompts of all others in the PACES exam, because mostly they can give it as a dummy case, like we have already discussed. A medical student can be given, or a nurse can be given. He or she will give you the history of taking painkiller, but forget to take the tummy protective medication, that is PPI. All of you know that CLD is a very much common case for the abdomen station in the PACES exam. So what they do, at one carousel, they keep this CLD as the short case station at abdomen. But at the next day with another carousel, they'll switch this patient as the long clinical consultation with the prompt of hematemesis. This usually happens every now and then. That's why the cases which have and overlap are very much important. There are multiple cases like this. Like in the neurology, you can get Parkinson's disease. This case can be given as a short case, or it can be given as a long case. The centers who have a scarcity of cases, they usually do this. And in case of hematemesis, CLD is also given as a case of switching over cases. So let's start the approach to hematemesis. So how to do the symptom analysis or the initial questions of hematemesis? First question is, may I know when it started? How many times did you vomit blood? What was the amount? What was the color of the blood? Was it bright red or dark red or coffee color? This question has an importance. If the hematemesis or bleeding comes from the esophagus, then it is bright. This will be bright red. But if the blood at some time or any part of the time comes in contact with the hydrochloric acid of the stomach, then it is going to be turned into dark red or coffee color. So stomach pathology will cause dark red vomiting or coffee color vomiting. But esophageal pathology will cause bright red vomiting. Keep this in mind, doctors. Then hematemesis can sometimes be confused with hemoptysis. So we have to rule it out also. How to rule it out? Just by asking this question, that was there any frothiness or it was mixed with film? If there is any frothiness or mixed with film, then it is hemoptysis. If it is not, then it is, we can make it confirm that this is a true case of hematemesis. Then the next question is, was there any food particle? Was there any blood clot? Presence of food particle or presence of blood clot means the bleeding is coming from the stomach. Because whenever blood comes in contact with hydrochloric acid of the stomach, it will result in blood clot formation. Then for any case of bleeding, we have to ask this question, that have you noticed any bleeding from any other parts of the body? The next question is, due to the bleeding, patient can get pale. So we have to ask, have you anyone told you that you are getting pale day by day? And due to this bleeding, patient can have...
ফ্ল্যাশ লাগে না
Yes, doctor?
ওই যে লাগে তো দিয়ে আসো সাউন্ড আসে তখন আরো
Okay. So if the bleeding occurs in a lot of quantity, the patient will have postural hypotension. And this is a red flag sign. We have to admit the patient. We have to rule it out from the history and from the physical examination. How to rule it out from the history? We have to ask, do you feel dizzy standing from the sitting position? So these are all the screening initial questions for hematemesis. I'm again repeating. When it started, how many times did you vomit blood? What was the amount? What is the color of the blood? Was it bright red or dark red or coffee color? Was there any frothiness or was it mixed with film?
ল্যাপটপ কিনতে কত টাকা
Then
লাগবে
was there
যে
any sound is
চার্জ
coming, doctor?
থাকবে
Please, you are requested to make them
আমার
mute
জন্য
because it is creating issue with others.
হ্যাঁ
So was there any food particle? Was there any blood clot? Have you noticed any bleeding from any other part of the body? Then have anyone told you that you are getting pale day by day? Then do you feel dizzy standing from the sitting position? So these are the initial question. Right after the asking the
না আমি
initial,
নিবো আমার জন্য নিজের জন্য
again the sound is coming. I'm not getting it found. Who is this?
ওরকম চললে নিবো হলে ভালো চলার জন্য
So you can mute everybody and whoever wants to ask question can raise the hand.
Actually, I don't know why I'm not able to mute one particular person. Some problem is there at my device to make the mute. Oh, I'm again requesting not to make the sound. Doctor, this is my personal request. Okay, let's proceed. So after asking the initial questions, we have to jump into the screening question of differential diagnosis. In the PACES exam, these 5 causes we have to keep in mind for any case of hematemesis. Apart from these 5 differential diagnoses, never ever any other causes has come, and it is very unlikely to come. It will never come. Our first DD is peptic ulcer disease. Second DD is ruptured esophageal varices. Third DD is malarious tear. Fourth DD is cancer. And fifth DD is hereditary hemorrhagic telangiectasia. So these are the 5 differential diagnoses for any case of hematemesis. So how to rule them out? To rule out the peptic ulcer disease, we have to ask, Dr. Sami has asked differential diagnosis. These are the differential diagnoses for any case of hematemesis. They are peptic ulcer disease, ruptured esophageal varices, malarious tear, cancer, and hereditary hemorrhagic telangiectasia. In peptic ulcer disease, the patient will have tummy pain. So we have to ask, do you have any pain at the tummy? The patient will have epigastric tenderness or epigastric pain there. And mostly it will be tummy case, except you will find the tenderness there. The patient will be instructed, the surrogate will be instructed that he will say, complain of pain whenever you are going to feel the epigastric region. To rule out the ruptured esophageal varices, we have to depend on the past medical history. The patient will give you some clue, like he is a diagnosed case of hepatitis B or a diagnosed case of hepatitis C. Some clue will be there, and he may not know that he has developed chronic liver disease. So to rule out the ruptured esophageal varices, again, we have to go to the PDF. Truly speaking, this PDF is true blessings for the PACES exam, especially for the long clinical consultation. Because whenever you are going to start the practice, also in the real exam, you will see the magic of past medical history, drug history, and family history. Then come to the malarious tear. Malarious tear happens whenever there is repeated episodes of vomiting. This causes some tearing in the lining of the esophagus. So we just have to ask, have you vomited repeatedly before this blood vomiting? I mean, again repeating, have you vomited repeatedly before this blood vomiting? This is the screening question for malarious tear. To rule out the cancer, again, the mighty mnemonic, triple L, loss of weight, loss of appetite, lumps and bumps in the body. If the patient complains of loss of weight and loss of appetite, surely you have to keep cancer in the differential diagnosis. That is going to be mostly esophageal cancer or stomach cancer. Anyone can be there. The last is hereditary hemorrhagic telangiectasia. In case of hereditary hemorrhagic telangiectasia, this is actually an autosomal dominant disease where the patient will have multiple telangiectasia at the mucosal lining. This is going to affect the nose, the GIT lining, like the esophagus. This is going to affect the lips and also the tongue. And also another part is that they are going to have some arteriovenous malformation. This arteriovenous malformation mostly affects the brain and the lungs. So the patient can present with brain hemorrhage and patient can present with hemoptysis due to this arteriovenous malformation inside the lung. But due to the telangiectasia, patient will have hematemesis due to the telangiectasia in the lining of the esophageal mucosa. The screening question is, have you noticed repeated bleeding from the nose? That is epistaxis. This will be the screening question for hereditary hemorrhagic telangiectasia because this patient will have recurrent epistaxis. So that's all for the differential diagnosis of hematemesis. Let me know whether any doctors have any confusion from this approach of hematemesis. Any question from anyone? Can I expect any question?
It's clear.
Okay. Yes, Dr. Malik, this was the second prompt. Okay, if it is clear, let me ask you a question. Suppose this case has been given, and in the cross questioning with the examiner, the examiner is going to ask you, how will you manage this case? Can I expect a volunteer to answer this question? Yes, Dr. Malik has given the right answer. Can anyone unmute and give the answer? This is simple thing, but why I'm discussing, because here a simple thing is missed, and the examiner expects that particular thing. Apart from admission and airway breathing circulation, do you think any important part you have to mention?
Whiteboard IV cannula.
Wonderful answer, doctor. Whiteboard IV cannula. Then
Blood matching, RH typing.
yes, doctor. Wonderful answer, doctor. This is the right answer.
And some basic investigation quickly, liver function test like.
That is later on. Blood opening to whiteboard IV cannula, cross matching, RH typing, and starting IV fluid. This simple thing, British examiner expect. And for unknown reason, some expert candidate needs to tell this simple thing. Things are that much simple. That's why I'm telling, in the PACES exam, candidate actually fail for making simple mistakes. They are not going to make a bigger mistake. That happens for everyone. Sounds clear, doctor? So never forget to open to IV cannula, blood grouping, cross matching, and starting IV fluid for any type of bleeding. It can be due to hematemesis, it can be due to melena. Our next approach, it can be due to any bleeding. And also after admission and airway breathing circulation. So that's all for hematemesis. Our next approach is melena. The differential diagnosis is going to be the same. So Dr. Malik has answered what APICS stand for in causes of dysphagia. Okay, doctor, we have to get back to the dysphagia approach again. I would like to discuss it at the end of that prompt session because it will take a lot of time. You can cover it from the recording also. After the prompt session finishes, you can ask it again, doctor. So approach to melena. The differential diagnosis of hematemesis and melena is going to be the same. Only the initial questions are going to be different. And here we have to understand something in terms of pathophysiology. So actually, what does melena means? Let me open a new. So melena means whenever there is black tarry stool. And this black tarry stool happens whenever there is upper GIT bleeding. This upper GIT bleeding means from the esophagus from the stomach or from the first part of the duodenum. It's called that up to the ligament of Triage. If any bleeding occurs from this part, then this will manifest as melena. So whenever any bleeding occurs from these sides, what will happen? Suppose bleeding is occurring from this side. So blood has to travel a lot way through the GI tract. It will travel down to the rest of the part of the duodenum, then ileum, then jejunum, then large intestine. All of this way he has to travel. During this traveling, he will come in contact with lots of bacteria. And these bacteria will do some treatment of the blood. They will change the color of the blood, resulting in the black tarry stool. Also, they will digest the blood, especially the heme component of the blood. And whenever digestion happens, some bad smell will produce. That's why anyone having melena will surely have foul-smelling stool. Stool will usually have foul smelling, that is usual. But this stool is going to have very much bad foul smell because the bacteria has got a chance to work on this blood. And we have to confirm it from the history. Not only that, we have to keep in mind that this blood is a good laxative. It is going to draw the water component from inside the gut wall. So it will cause some loose type stool. Not loose, it will cause some pasty stool. It is called the pasty or sticky stool. It will have a tendency to stick to the pan. So whenever you are going to flush, it is going to stick to the pan. It will not float, it will just stick to the pan. And it happens because it is a good laxative, it becomes something like the paste. Why I am telling this? Because also in real life, you can get some constipation cases presenting as black tarry stool. So whenever anyone is complaining of black tarry stool, we have to ask about the consistency of the stool. If it is hard consistency, then surely it is constipation. But in order to tell it melena, we have to confirm whether this is pasty or sticks to the pan, whether this is foul smelling, and whether it is also black tarry. So this is how we have to differentiate melena from the constipation. Let me know from the doctors whether this pathophysiology is clear to all. Okay. Only one doctor clear? Okay. So
Yes, sir.
what should be? Yes, doctor. Yes, doctor. Anyone asked a question?
No, sir. Clear, sir.
Okay. So what should be the initial questions? The first question is, for how long you are having this problem? Has it happened for one time, or is it occurring with every motion? Then is it happening for the first time? Like it is happening for the first time with every motion? This is whether this is the way or not. Then we have to ask, what is the color? Is it bright red or dark red or coffee color? If it is bright red, then surely this is not a case of melena. This is lower GIT bleeding, that is hematochezia. Then we have to ask about the consistency to differentiate from constipation. We have to ask, what is the consistency? Is it hard and well formed, or pasty and tarry that has a tendency to stick to the pan? That is, does it stick to the pan? The last question is, any foul smell? So these are the initial questions for melena. After asking the initial questions, we can jump into the differential diagnosis, which is going to be the same as the hematemesis. They are the peptic ulcer disease, ruptured esophageal varices, malarious tear, cancer, and hereditary hemorrhagic telangiectasia. We have discussed what should be the screening question for each in our previous prompt.
Why it cannot be inflammatory bowel disease?
Inflammatory bowel disease usually does not present with melena. It presents, there are two types of inflammatory bowel disease. One is Crohn's disease, another one is ulcerative colitis. Ulcerative colitis mostly affects the descending colon or the rectum. That will present with hematochezia. That is bright red bleeding.
Yes.
Ulcerative colitis does not affect the esophagus or the stomach or the duodenum. That's why ulcerative colitis does not present as melena. Did you get the answer, doctor?
Yes, sir. Yes. But in Crohn's, we don't get any bleeding, isn't it?
Actually, Crohn's disease does not manifest as bleeding. It
Yes.
manifests solely on diarrhea.
Yes.
Clear, doctor? Should I proceed to the next prompt? Okay. So our next prompt is loose motion. It is also going to be the triple star prompt, and this is very much important. I can surely bet that at every diet, this case is going to come. And this is coming for every diet. This is a very much popular prompt, and this is going to come at every diet. almost at um, at every carousel also. So how to approach to a case of loose motion? Just let me drink some water. Okay. So in the PACES exam, 3 types of loose motion comes. One is watery, another one is malabsorptive, another one is bloody. How to differentiate them, I'm going to discuss in detail. So what should be the initial question of loose motion? Our first question should be, what do you mean by diarrhea or loose motion? How many times you have to go to washroom daily? What is your usual bowel habit? We have to confirm it. We have to make it confirm in front of the examiner that we are confirming this is a true case of loose motion. This has to be something different from the usual bowel habit of the patient. Then the second and the most important question is what is the nature of your bowel? Is it bloody or watery? Or is it pale, greasy, and difficult to flush? Right after this question, we can differentiate our differential diagnosis. So this is going to be the most important question. That is, what is the nature of your bowel? Is it bloody? Is it watery? Or is it pale, greasy, and difficult to flush? This pale, greasy, and difficult to flush is for malabsorption. Then our third question should be, does it improve by fasting? Why it is important? There are some diarrhea which is called secretory diarrhea. So what happens in case of secretory diarrhea? In case of secretory diarrhea, there happens to be a continuous inflammation in the gut wall. So whether you put food bolus or not, whether you give food to the patient or not, that inflammation is going to will continue, and that inflammation in the gut wall will present as diarrhea. This inflammation can happen in case of Crohn's disease. It can happen in case of ulcerative colitis. It can happen in case of cholera. So these will not depend on the food. Independent of the food, the inflammation will go on the gut wall. That will manifest as diarrhea. So but in case of celiac disease, in case of lactose intolerance, it will solely depend on the food. If you don't give the patient the gluten-containing food, the patient is not going to have diarrhea. If you don't give the patient the milk, the patient will not going to have diarrhea in case of lactose intolerance. So we have to ask this question, whether this diarrhea gets improved by fasting. The fourth question is whether it is improved by sleeping. That is, have you ever wake up at night to go to the washroom? This is also going to be a very important question, because any organic pathology is going to interrupt the sleep. But if any time the diarrhea improves with sleeping, this is surely going to be IBS, that is irritable bowel syndrome. I'm again repeating, any organic pathology causing loose motion will interrupt the sleep must. But if the loose motion gets improved by sleeping, then this is IBS for sure. The next question is incomplete evacuation and sense of urgency. Before that, I have to make you understand the pathophysiology of that. Let me draw a diagram. Suppose this is our rectum and this is going to be the anal canal. So if anything occurs in this rectal wall, suppose this can be an ulceration due to ulcerative colitis or due to proctitis, or they can be this is a growth like cancer. This is going to create continuous irritation to the rectal wall. So the patient will feel continuous irritation. Usually, when the fecal matter comes through this way, when it comes in contact with this rectal wall, we feel the sense of evacuation. We have to open our bowel. After it becomes empty, then we feel that we have opened the bowel completely. But if something happens in this gut wall, like there is a continuous irritation, there is an ulceration, there is a tearing, and there is a growth, this irritation will not depend whether we have emptied the bowel or not. So even after completing the bowel, the patient will feel that something is left behind. This is called sense of incomplete evacuation. This can happen in case of ulcerative colitis. This can happen due to rectal carcinoma. This can happen also due to the proctitis. This proctitis can happen in case of HIV patient due to some unusual sexual behavior. Sometimes it can cause some intense irritation that patient will feel that he has to open his bowel urgently. This is called urgency. And from the history, we have to rule them out. How to ask this question? To rule out the incomplete evacuation, we have to ask some people with bowel problems describe a feeling that they have not fully emptied bowel after going to the toilet. Do you feel the same? This is the question of incomplete evacuation. To rule out the urgency, we have to ask, do you ever feel a sudden strong urge to pass stool that you cannot hold it back? Let me know from the doctors whether everyone has gotten understood how incomplete evacuation and urgency pathology happens and how to rule them out. Is it clear to all doctors? Okay. Then for any case of loose motion, like the hematemesis or melena, this can cause postural hypertension due to the dehydration, due to the volume loss. So we have to ask this question, any dry mouth, dizziness upon standing, to rule out dehydration. If the patient complains at any time that he is having dry mouth, he is feeling dizzy upon standing, we have to admit the patient. So this is all for the initial questions of any case of loose motion. I will suggest to make it memorize so that whenever you get any loose motion, you have to ask this question one by one. That what do you mean by diarrhea? To confirm this is a true case of diarrhea, how many times do you go to washroom daily? What is your usual bowel habit? What is the nature of your bowel? Is it bloody, diary, or is it bloody, watery, or pale, greasy, and difficult to flush? Does it improve by fasting? Have you ever wake up at night to go to the washroom? Then some people with bowel problem describe feeling that they have not fully emptied after going to the toilet. Do you feel the same? Do you feel a sudden strong urge to pass the stool that you cannot hold it back? This is for urgency and any dry mouth, dizziness upon standing. Let me know from the doctors if anyone has any confusion from these initial questions of loose motion.
So, sir, can you tell me again that what type of loose motion is improved by fasting? Lactose intolerance, celiac disease, and
That are the two diseases I know.
okay.
If it is clear, then we can jump into the differential diagnosis. Regarding the differential diagnosis of bloody loose motion, if we come from the second question, that what is the nature, the patient complains that he also notices some blood during loose motion, then the differential diagnosis is the rule of I. But before that, we have to rule out some two other differential diagnoses. They are hemorrhoids and anal fissure that can also manifest as parectal bleeding. So to rule out hemorrhoid, we have to ask any pain while, to rule out the anal fissure, we have to ask any pain while opening the bowel. To rule out the hemorrhoid, we have to ask, have you noticed anything coming out while opening the bowel? These are two local pathology. One is hemorrhoid, another one is anal fissure. For any parectal bleeding, we have to rule out these two local pathology. Then we can jump into the differential diagnosis. We have already discussed in our introductory session that for diarrhea, we have to take the pet history. For cough, diarrhea, fever, and joint pain. Here, travel history is very much important. We cannot forget the travel history. Also, not only travel history, sometimes the patient can deny of travel history. It has happened at Delhi, this day. We have to ask, have you taken food from outside? So we have to ask about the food history. If the patient denies of travel history, I'm repeating, if the patient denies of any travel history in the prompt of loose motion, ask about the food history. That did you take food from outside? So what are the differential diagnoses of bloody loose motion? They're infection or inflammation or infiltration, that is cancer, or infarction. Regarding the infection, the bug that can cause bloody diarrhea are the Salmonella, Shigella, Amoebiasis, or Campylobacter. Patient will surely give you some travel history or taking food from outside. For inflammation, it is inflammatory bowel disease. We have to rule it out by asking the screening question of eye redness, joint pain, and skin rash. That are the extraintestinal features of inflammatory bowel disease. For infiltration, that is cancer. Can anyone repeat it for me? What are the screening questions for cancer?
Lots of appetite.
Loss of weight, loss of appetite, lumps and bumps anywhere in the body.
Thank you, doctor. Yes. And for infarction, it is actually a surgical case. It has not come up to now, but in the patient will have some form of atrial fibrillation when you are going to feel the pulse. It has not come up to now. It is mostly a surgical case, so it is less likely to be given in the PACES exam. So these are the differential diagnosis of bloody loose motion. But before that, I have missed one important thing about loose motion. The thing is that for every kind of loose motion, whether it is bloody, whether it is watery, or whether it is malabsorptive, you can keep two differential diagnoses for any case of loose motion given in the world. For the PACES exam. One is infection. Another one is inflammatory bowel disease. Please keep in mind this important point. This is a shortcut technique. For any case given in the PACES exam, at the long clinical consultation with the prompt of diarrhea loose motion, you can keep these two differential diagnoses in your list. You can tell one after another. You can keep IBD first or infection first, but these two will be there for all the differential diagnoses. This is 100% guarantee. Even the patient may deny any extra articular manifestation of IBD, like the eye redness, joint pain, skin rash. Even in the absence of them, you can keep IBD as your differential diagnosis. And for any case of loose motion, we have to rule out infection also. So infection and IBD is a common DD for every kind of loose motion. Let's keep this in mind. Yeah, Dr. Malik has asked HIV, TB. HIV and TB is considered as a form of infection, doctor. So under this category of infection, we have covered the HIV, TB, Salmonella, Shigella, all of them. But HIV or TB will not manifest it as bloody loose motion. They will manifest as watery loose motion. So may I know if there's any question from the differential diagnosis of bloody loose motion? Then we'll proceed to the next. Okay. The next DD is for the watery and the malabsorptive loose motion. And the DD is going to be the same for both. So I'm just going to tell that the differential diagnosis of watery loose motion or the malabsorptive loose motion is going to be the same. Any pathology that can cause watery loose motion can also cause malabsorptive loose motion. There is a mnemonic I have prepared. The mnemonic is DISCORA. Here D goes for drugs, I goes for infection, S goes for systemic sclerosis, C goes for celiac disease, R goes for radiation, E goes for endocrine, and P goes for pancreatitis, that is chronic pancreatitis. So inside the drugs, that is from first part of the DISCO, it can be caused by PPI. It is called lymphocytic colitis. Anyone taking PPI for a long period of time, it can cause diarrhea. It can be due to any recent use of antibiotic that we have already discussed, that is pseudomembranous colitis. It can be due to use of laxative frequently. It can be due to use of mycophenolate mofetil. This case has come 3 times in the PACES exam. 1 time at the UK, 2 times at the UK, and 1 time at the Thiruvananthapuram. Another cause is colchicine. So I have already discussed that Parkinson disease and myasthenia gravis, this case can be switched over neurology and the LCC. Can anyone guess among the PACES cases where you can get the exposure to the mycophenolate mofetil at which shortcake station?
Renal transplant or liver transplant.
Renal transplant or liver transplant. That is why they can keep this liver transplant or renal transplant at one carousel as a abdomen station. At another station, at another carousel, they will switch this case with a long clinical consultation of loose motion. Wonderful, doctor. Then the next I is infection, IBS, and IBD. Here the infection may be viral, giardiasis, TB, or HIV. If anytime the patient complains of traveling to India and he is having loose motion for quite a long period of time, like 15 days to 1 month, then surely this is going to be giardiasis. And TB, if the patient is traveling to India or you are giving exam in the India, then this can be TB, also HIV. So regarding this part, or especially the HIV, I'm going to discuss an important part that is true, that has happened with one of my friends. Actually, for the PACES exam, whatever the age of the patient, never dare to take the sexual history. Because one time, one of my friends who appeared at Thiruvananthapuram, he got a patient of 75 years old who is coming with the complaint of loose motion. So looking at the age of the patient, he did not take the casual exposure history, which was there. Whenever he got the feedback, he saw that he had exposure to the multiple partners. So automatically HIV will come as a differential diagnosis there. So he missed his first mark at that attempt. He's now working at the UK, but never dared to take the casual contact history. Don't be judgmental based on the age of the patient. Even if you have been given a case of 90 years patient, follow the format of taking casual contact. So this is for infection. Then the next cause is IBS, that is irritable bowel syndrome. And I have already discussed this IBS loose motion will be improved by sleeping. That is, the patient will not have to get up from sleep to go to the washroom. And there are certain other symptoms of IBS. This is just a screening question. This is just a screening question, and the patient will have some other features. What are the other features of IBS? Patient will have some mood issue, such anxiety. Yes, Dr. Malik has asked, should I ask or not casual sexual history? Yes, doctor. For every case of diarrhea, I have already mentioned the PAT history, cough, diarrhea, fever, and joint pain. For every case of diarrhea, never forget to take the casual contact history. Don't just look at the age of the patient. Take history of casual contact. So let's come to the symptoms of IBS. The patient will have some mood problem or anxiety. You have to ask about it. What about your mood? Then the patient will have some bloating sensation. That is, he will feel full after eating. This is symptoms of IBS. Then the patient will have loose motion, but in between loose motion, he will have constipation. So we have to ask this question that in between loose motion, do we have any constipation? It is called alternative constipation and diarrhea. And the final point is, do you have any tummy pain? And is the tummy pain improves after opening the bowel? Because what happens in case of IBS, patient feels some periumbilical pain and the pain is improved after opening the bowel. So these are the questions. First one is mood problem that we have to ask. Do you have an anxiety? Do you feel bloating after eating? In between the loose motion, do you have any constipation? And do you have any tummy pain that is improved after opening the bowel? These are all the features of irritable bowel syndrome. Then come to the inflammatory bowel disease. I already mentioned infection and inflammatory bowel disease. You can keep as any as a differential diagnosis for any loose motion for the PACES exam. But to rule it out, we have to ask the extra intestinal features of inflammatory bowel disease, like the joint pain, skin rash, and mouth sore. But even in the absence of them, we can mention them. We can mention them for any short-term diarrhea. We can mention them for any long-term diarrhea. We can mention them for any bloody loose motion. We can mention them for any watery or malabsorption loose motion. Please keep this important thing in the mind. So after D, here comes a S for this. Here S goes for systemic sclerosis. This case has come multiple times in the exam. And actually systemic sclerosis is a popular case in the PACES exam. This systemic sclerosis patient can be given with many problems, like the swallowing difficulty, loose motion, hand pain. So we have to be careful about this. Another S goes for short bowel syndrome. To rule out the systemic sclerosis, we have to ask about the skin thickening. And short bowel syndrome means patient had some surgery where part of the bowel has been resected, and right now patient is having diarrhea. This is called the short bowel syndrome. So we have to depend on the past medical history of surgery. We have to take this history. No other screening question apart from the past medical history. Then come to the celiac disease. In perspective of UK, any young patient presenting with chronic diarrhea, we have to rule out celiac disease, even if the patient does not complain of any relation to the food containing gluten. Like we have to ask that, have you, to rule it out, we have to ask, have you noticed any relation to any particular food like bread, pasta, or barley? This is the usual question. But if the patient is young and he is having chronic diarrhea means diarrhea happening for 20 days to 1 month. For that case, we have to keep celiac disease even as the last differential diagnosis. Because if you read the NICE guideline, you'll see that this is written there. And it is the most common cause of iron deficiency anemia in the UK, even in asymptomatic individual. So they screen all the individuals for celiac disease, even if he does not complain of loose motion. So keep in mind, for UK, any young patient having chronic diarrhea, we have to rule out celiac disease, even in the absence of any symptoms like relation to any gluten-containing food. Then radiation enteritis. It will depend on the past medical history. This case has not come up to now. E goes for endocrine, that is hyperthyroidism. To rule it out, we just have to ask about weather preference. Do you have any weather preference? In case of hyperthyroidism, the patient will prefer cold weather. Then to rule out the pancreatitis, we have to ask about the tummy pain. Patient will have chronic epigastric pain. And there will be some cause of chronic pancreatitis, like taking alcohol, which is the most common one. So these are the differential diagnoses of watery and malabsorptive diarrhea. I'm again repeating, infection and IBD. Keep them as common for all the cases of diarrhea. Let me know from the doctors whether anyone has any question from any of the differential diagnoses mentioned here. Okay, there's no question. So what I'm going to discuss right now is that the simple thing that is most very easily by many candidates. That is, if you get a case of diarrhea, Most of the time you'll get it a dummy case. Never miss to examine the bowel sound for any case of diarrhea. I can give you a guarantee. If you miss to examine the bowel sound, you are surely going to lose your mark in the physical examination. This is guaranteed. So any case of loose motion, never miss to examine the bowel sound. Please never forget it. And this is the easy part. At the same time, this easy thing is missed. Yes, we have to do the full examination, doctor. And the sequence of examination, we'll get it in the separate section. But this is the, I have just mentioned it because this simple thing is missed most often. I have already told that PACES exam is usually missed by making simple mistakes, not a grave mistakes. And this is one of that simple mistakes where you will lose the marks for surely if you don't examine the bowel sound. You will not get any. No, it is not needed to examine for 30 seconds. You can examine just for 10 seconds. The examiner will assess whether you have examined the bowel sounds or not. 10 to 20 seconds is more than enough. You will not get any positive physical findings because any real diarrhea patient will never be given to you. The patient who is having loose motion, will he be stable enough to give him at the PACES exam? Never. So we have to just act to examine the bowel sound. And my request is again, never forget to examine the bowel sound. And also in young patient with diarrhea, always keep celiac disease in the differential diagnosis in case of chronic diarrhea and offer digital region examination at the end. So that's all for diarrhea, loose motion. Before proceeding to the next prompt, that is the abdominal pain, let me ask finally whether anyone is having any confusion from this super duper important prompt of loose motion.
Bhaiya, what about the pancreatitis key question? Tummy pain.
Yes,
Upper
tummy pain.
digestive.
Tummy pain. Epigastric tummy pain. Any other question? No other question? Okay. Actually, without question. Okay, if there's no question, then let's proceed to the next prompt. The next prompt is abdominal pain. This is going to be the last triple prompt. Before approaching for abdominal pain, I want to discuss in detail about some pathophysiology. Because once you understand the detailed pathophysiology, then it will be easier for you to get to the diagnosis. So regarding all of the pain in our body, there are basically three types of pain we feel. One is somatic pain, another one is neuropathic pain, and the last one is visceral pain. So somatic pains mean whenever there is, sorry, let me change the color. So somatic pains mean this is the nerve and this is going to a muscle. Whenever any pathology is happening in that part of the muscle, this is going to be sensed by that nerve, and this nerve is going to give signal to the brain that this tissue is dying. This is called somatic pain. We can localize the pain at a specific part of the body. We feel this type of pain in case of burning, in case of trauma. We feel this localized pain. In case of neuropathic pain, the problem does not happen with the muscle. The problem happens with the nerve itself. This can happen in case of any peripheral neuropathy, like diabetic, like any case of like alcohol. And the type of pain here the patient will feel is the tingling, numbness, burning type of pain. This is not going to be any localized pain. This type of pain is called the neuropathic pain. Here the pathology is inside the nerve, not inside the muscle. But in case of somatic pain, the pathology is inside the muscle, not inside the nerve, and we can pinpoint localize the site of pain. So this goes for somatic pain and neuropathic pain. But what happens for the visceral pain? The visceral pain does not have any nerve itself. It does not have any somatic nerve. He's basically painless, truly speaking. So whenever any pathology happens to him, he hijacks the somatic nerve of the overlying organ. Like if anyone is feeling, if anyone is having pathology in the liver is going to take the somatic supply of the skin overlying it. Also, sometimes it can hijack the nerve supply of the organ where it originates embryologically. That's why we feel the referred pain. Like whenever anyone is going to be hit in the testis, he's going to feel pain in the tummy. Whenever anyone is having cardiac MI, he is going to feel pain at the left hand. Whenever anyone is going to have cholecystitis, he is going to refer pain at the tip of the shoulder. This is happening because of some embryological origin relation. But truly speaking, visceral organ does not have itself pain fibers. It hijacks the pain of the overlying skin, both of the current position and of the embryological origin. And the viscera can create pain in 3 conditions. One is whenever it gets obstructed. It can cause pain whenever it is stretched. Like there is a capsule over each viscera, and whenever this capsule gets stretched, then it can cause pain. It can cause pain whenever there is inflammation. I'm going to give you an example of each one, and this is necessary to make it understand. It can cause pain whenever there is perforation. It can cause pain whenever there is ischemia. So let me discuss one by one. Whenever the viscera gets obstructed, it can cause pain. In order to get obstructed, the viscera needs to have lumen, like the bile duct, like the ureter. Whenever anyone is having cholelithiasis, it will cause some obstructive pain. The type of pain is the colicky type of pain, and the patient will describe you crampy type of pain. Because the peristalsis wants to remove the blockage. Whenever anyone is having ureteric stone, this will cause some colicky pain. Whenever anyone is having intestinal obstruction, this will cause colicky type of pain. So the type of pain here the patient will feel is the colicky type of pain. And in order to have the colicky type of pain, the viscera has to have some lumen inside it. Is it clear to all, doctors? Am I being able to make it understand? Okay. The next thing is stressed. Whenever the capsule outside the viscera gets stressed, it can cause pain. Example is whenever anyone is having hepatitis, it will cause swelling of the liver. Whenever anyone is having pyelonephritis, it is going to cause the swelling of the kidney, resulting of stretching of the capsule manifested as a pain. Then whenever there is inflammation, like whenever anyone is having gallbladder stone, initially it will cause colicky pain, that is pain due to obstructive in nature. But when the stone will stay there for a long period of time, it will cause irritation of the bowel wall, resulting in inflammation. So this will cause pain. Anywhere in the viscera, if you get any inflammation, this will cause pain at that organ. So cholecystitis will cause pain. Pyelonephritis will cause pain for 2 reasons. One, for the stretching of the capsule, another for the inflammation of the glands itself. In hepatitis also, the pain can be produced. The pain will be produced due to the stretching of the capsule, also due to the inflammation of the gland organ itself. In diverticulitis, patient will have pain due to inflammation. In ulcerative colitis, again patient will have pain due to inflammation, mostly left lower quadrant pain. So these are the causes of pain, 1 to 3, that is obstructed, stressed, and inflamed. Visceral pain can be caused due to perforation also. We all know that if any gas containing hollow viscous gets perforated, then the bowel content will leak out and it will cause pain, causing irritation of the whole bowel wall, of the whole internal organ. So this is another type of pain. The last type of pain is ischemia. In case of ischemia, the blood supply to the bowel will get interrupted. So when the blood supply to the bowel can get interrupted, our bowel has some blood supply. These are mostly medium-sized vessels. This blood can supply directly to the bowel wall, or it can supply the mesentery. So like peripheral vascular disease, anyone is having long-term diabetes, dyslipidemia, this patient can have peripheral vascular disease, like one of his lower limb blood vessel can get obstructed. Like the same way, these mesenteric vessels can get obstructed, resulting in bowel ischemia. Also, in case of vasculitis, like the medium vessel vasculitis, in case of medium vessel vasculitis, there happens episodic inflammation. And whenever the inflammation happens, it causes constriction of the medium vessel arteries, resulting in impairment of the blood supply. So whenever there is blood supply gets interrupted, it will cause ischemia, resulting in bowel pain. And this type of bowel pain will mostly happen after taking meal, because it is that time when the bowel has to work perfectly. So after you put the food bolus into the bowel, after when the food happens to pass there, like 30 minutes to 1 hour later, at that time the patient will feel pain. And due to the fear of that pain, patient will not eat that much. And in case of this bowel ischemia, the patient will complain of severe pain. But whenever you are going to examine the patient's tummy, you will find soft abdomen. Sometimes in rare case, you may find think that patient is mimicking. But whenever you are going to measure the serum lactate, you are going to find it high. I'm going to discuss it because of the whole understanding of this conception of visceral pain. So let me ask from the doctors whether the causes of visceral pain is clear to all, how the pain can be caused whenever any viscera gets affected. Again, I'm telling you, viscera does not have any pain fiber itself. Like whenever you are going to cut your liver from inside, you will never feel that pain. This is happening. This is happening due to one of these pathology. Like if it is obstructed, if the capsule gets stressed, if it is causing some inflammation due to irritation, if it is causing perforation, if it is causing ischemia, at that point you will feel the pain. It is true for all the viscera inside our body. One of the doctors have asked, is it dull or colic? Dr. Colicky pain is there whenever there is a chance of getting obstructed. Like the viscera has some lumen inside it. Like our colon has some lumen inside it. Our ureter has some lumen inside it. Our bile duct has some lumen inside it. For that case, you'll feel the colicky pain. Otherwise, you'll feel the dull pain. Dull pain is there due to the stretching and perforation. Sorry, stretching and inflammation. For perforation, it will be a diffuse pain. It will be like acute abdomen-like pain. And in case of ischemia, it will be something like periumbilical pain. So, is there any question from any of the doctors? Have you got to understand the pathophysiology of visceral pain? Right after that, I will jump directly into the differential diagnosis or how to narrow down the diagnosis of abdominal pain.
In inflammation, what type of pain will occur?
Dull pain.
Dull pain. Inflammation, perforation, dull pain.
But in perforation, it will be diffuse pain. But in place of inflammation, it will be localized dull pain.
Okay. And what about stressed? Swelling of liver, capsule?
Dull pain, localized dull pain. I have described this to make you understand why we feel pain whenever any of our viscera get affected. If it is possible that I'm going to dissect your liver from inside of your body, you will never feel the pain. This is truth for every organ inside our brain, including the lungs, including the liver. It is only when the capsule gets stressed or any inflammation happening or anything getting obstructed or perforated or getting ischemia, at that time you are going to feel the pain. Also, by hijacking the somatic nerve, because viscera does not have its own somatic nerve. Sounds clear, doctor? Should I proceed? Okay. So how to approach to a case of abdominal pain? In this case, we can analyze the symptom using the mnemonic ODPARA, that is onset, duration, initial episode, progression, aggravating factor, relieving factor, and associated features. All of the questions has been discussed in detail in our introductory session. Then we have to analyze the pain using the mnemonic LICOR, that is location, intensity, quality, and radiation. This is true for all the pain. Then in the PACES exam, two types of tummy pains come. One is recurrent episodes of tummy pain, another one is first episode of tummy pain. If the pain is recurrent, that is, it is coming and go, then there are 4 differential diagnoses for the PACES exam. One is hereditary angioedema. Then another one is acute intermittent porphyria. Another one is familiar Mediterranean fever. And last one is irritable bowel syndrome. I'm again repeating: hereditary angioedema, acute intermittent porphyria, familial Mediterranean fever, and irritable bowel syndrome. In case of hereditary angioedema, acute intermittent porphyria, and familial Mediterranean fever, all will have positive family history because they are genetic disease. In case of hereditary angioedema, along with the tummy pain, patient will have breathing issue. You will be given absolutely dummy patient. She will tell you that I am having recurrent tummy pain. So to rule out hereditary angioedema, first you have to ask that during the episode of tummy pain, do you have breathing issue? If he replies yes, then this is a case of hereditary angioedema, and be careful of the family history because he or she is going to give you some clue from there that one of his father or mother or one of his sisters or siblings has the same type of tummy pain. Then acute intermittent porphyria. In case of acute intermittent porphyria, it is a case of autosomal dominant disease where there is some defect in hemoglobin metabolism. It results in the buildup of porphobilinogen deaminase, porphobilinogen inside the body, in the blood. The screening question will be change in the color of urine, after exposure to light. That is, have you noticed any change in the color of urine after exposure to the light? This will be the screening question of acute intermittent porphyria. Actually, what happens in case of acute intermittent porphyria? This toxic product, that is the porphobilinogen, gets accumulated in the urine. So whenever it comes in contact with the sunlight, the color changes. It turns into dark color. Also, this toxic product crosses the blood-brain barrier, affecting the CNS and also the peripheral nervous system, autonomic nervous system. Whenever the CNS is affected, it can cause some neuropsychological feature like anxiety, depression. Also, it can cause some seizure-like feature. It can cause some epilepsy. So the patient can be mistakenly diagnosed as a case of epilepsy. He or she may have some recurrent episode of conversion. Whenever the autonomic nervous system is affected, this causes the tummy pain. Usually, this type of patient gets recurrent admitted into the emergency department. So sometimes they may be mistakenly diagnosed as having a case of appendicitis, and some of them have operation for that, while it is not actually the true case. So this is how the acute intermittent porphyria gets presented, and we have to ask that by asking the screening question that any change in the color of urine after exposure to the light. Then come to the familial Mediterranean fever. This case is given mostly in the Middle East center. In case of familial Mediterranean fever, It's a type of serositis. Here the patient feels pain due to the peritonitis. Apart from peritonitis, it will also affect the capsule of the joint, especially the knee joint, because it is a type of serosa. So apart from tummy pain, patient will have knee pain. We can rule out familial maintenance fever just by asking this question. That apart from tummy pain, do you have any knee pain? Yes, doctor, chest pain can be there because pleural can be there. Pleural is a type of serosa. So you can ask about, mostly the patient has joint pain, but chest pain can be also there. So you can use joint pain as the screening question. And last is irritable bowel syndrome. To rule it out, just ask, does the tummy pain improves after opening the bowel? Because in case of IBS, the tummy pain will improve after opening the bowel. And that's all for the recurrent episode of tummy pain, differential diagnosis. May I know, is it clear to all the doctors? Any question from anyone? Some of the doctors have got clear. Okay. Yeah, clear.
Can pancreatitis have recurrent episodes of tummy pain as well?
In the
Recurrent
PACES exam, actually pancreatitis case is given is a case of acute episode. That is the first episode. Chronic pancreatitis is usually not given with the prompt of tummy pain. In real life, you can get, but I'm discussing on perspective of PACES cases. Got it, doctor?
Okay.
Okay, thank you, doctor. Then come to the mighty first episode of tummy pain. Again, before discussing it, I want you to understand something very important. That is the organs that lies at each quadrant. So these are the 9 quadrants of our tummy. This is right hypochondrium. This is left hypochondrium. This is epigastrium. This is right lumbar, umbilical, left lumbar. Then this is right iliac, left iliac, and this is suprapubic. So in order to make it understand, first you have to know which organ lies at each quadrant. So in case of right hypochondrium, if we think there are certain organs here, especially the lower part of the right lung, there is diaphragm also, and there is liver also. So any pathology happening in these organs may cause right hypochondriac pain. But that does not mean that for passing the LCC exam, you have to know all the pathology for these organs. You have to keep your mind, you have to use your sense. Like lungs and diaphragm pathology will never be given in the PACES exam because diaphragm pathology is a surgical case. Anyone having road traffic accident or major traffic accident, he is going to have some diaphragmatic tear. This is a surgical case, so you can rule it out for PACES case. And lung-related pathology also will never be given. It is 100% guaranteed with the prompt of right hypochondriac pain. So only liver is left. So any right hypochondriac pain, just consider the liver pathology. What are they? They are either hepatitis or liver abscess or Budd-Chiari syndrome. And that's all. This Budd-Chiari syndrome actually came at Thiruvananthapuram. It was a case of tender hepatomegaly with ascites, and the patient used to take OCP, and she had a past medical history of having unprovoked deep venous thrombosis. This case came at the Thiruvananthapuram center. Sounds clear, doctor? Is it clear to all? What are the differential diagnoses of right upper quadrant pain? Should I proceed forward? Yes, doctor. Budd-Chiari syndrome came as the prompt of tummy pain. The patient was having tender hepatomegaly with ascites. This case came at Thiruvananthapuram of India. In the past medical history, the patient was having not any hematological condition. The patient was taking oral contraceptive pill. Oral contraceptive pill is itself a prothrombotic factor. And also there was a past medical history of unprovoked deep vein thrombosis. These are the only two clues given in the case. These cases, those who have already enrolled for type 1 or type 2, you are surely going to get this case in there. This case is there. So this is for right hypochondrium. Let's come to the left hypochondrium. What are the organs that stays here? Basically, they are lungs, diaphragm, and spleen. And no pathology is there related to the medicine. Lungs pathology presenting with left hypochondriac pain will never be given in the basis exam. And diaphragm and spleen pathology are surgical case, like diaphragmatic tear or splenic hemorrhage. They are surgical case. They happen due to the trauma. So you can remove from your mind that left hypochondriac pain will be given in the basis exam. So you can skip this part. Next, come to the epigastrium. So in the epigastrium, what are the organs that can lie, or that what are the organs where pathology can manifestation? The organs are heart, stomach, and pancreas. So any patient presenting at LCC with the prompt of epigastric pain, we can keep these three differential diagnoses. One is peptic ulcer disease affecting stomach, pancreatitis affecting pancreas, and acute coronary syndrome if in the past medical history patient is having some risk factor for this. And this is very much common. Sometimes they will give you a case like 50 years old male, he is taking painkiller, he is having diabetes, he is a smoker. So apart from peptic ulcer disease, you have to rule out acute coronary syndrome. This is a very much important cause, that is epigastric pain. So let me know if it is clear to all. Clear, doctors?
Clear.
Okay. Then come to the left and right lumbar region. In the left and right lumbar region, mostly the kidney resides. And in the PACES exam, it is given as a case of pyelonephritis. This case came one time at the Pondicherry. I have already mentioned that, at the Pondicherry, the prompt was low back pain. But at another center, the same case came as tummy pain. And the cause was pyelonephritis. It was right lumbar region pain. Also, not only pyelonephritis, it can also come as a case of ADP-GIT cyst rupture. These cases come in the PACES exam. That patient is having right lumbar pain, and he has a past medical history of hypertension. In the family history, his father died of bleeding inside the brain. So the past medical history, and drug history is going to give you a clue that this is a case of ADP-GIT.
Sir, do they give renal calculi also?
No, doctor, usually not given. Usually, renal calculi also is a surgical case mostly. You can get in association, like sometimes hyperparathyroidism case can be given as a component of main one, where you will get history of having renal stone. But the patient is not coming to you right now due to the renal stone. This is usually not the PACES case. Got it, doctor?
Yes, sir.
Okay. Then right lower quadrant pain. In the right lower quadrant, this is the right lower quadrant, the right iliac region. What organs reside here? They reside the ileum, cecum, appendix, and ovary. Regarding the appendix, appendicitis is a surgical case, so this is not going to be given in the PACES exam. Regarding the ovary, ovary can have multiple pathology, like ovarian torsion, then ovarian cyst rupture, but this is not a gynecological exam. So this case will never be given to you. So we just have to remember the pathology of the ileum, the pathology of the ileum and cecum. What are the pathology there? This can be inflammatory bowel disease, like Crohn's disease, ileocecal TB, and also the malignancy. Then come to the left lower quadrant. In the left lower quadrant, there resides the sigmoid colon and the part of the rectum. And it is the sigmoid colon where the diverticula mostly forms. Also, in the sigmoid colon, ulcerative colitis has a great tendency to happen. So what are the differential diagnoses of left lower quadrant pain? They are diverticulitis, ulcerative colitis, that is inflammatory bowel disease, also malignancy. Now only the periumbilical region is left. In the periumbilical region, or we can call it diffuse pain, it can be due to infection or IBS or vasculitis. This vasculitis can be due to IgA nephropathy or polyarteritis nodosa, or this diffuse pain can be due to peritonitis, but this pain will be severe like acute abdomen. So these are the differential diagnoses based on the quadrant. I think session is getting bored. Let's start with some real PACES cases. Let me see who can give the answer. Okay, right now I'm going to give you some cases and I will assess who can give the right answer based on this approach. And I'm going to discuss some real PACES cases. Yes, doctor, DK can, sorry, DK was missed here. Yeah, the periumbilical pain will also, we can add DK here. But Addison's disease presentation is not with abdominal pain. Addison's disease is given in the PACES exam with the prompt of collapse or postural dizziness. It is not given with the prompt of abdominal pain. But DK can present with periumbilical or diffuse pain. It is truth. So let me give you some example. Right now, I would like to have some one-to-one interaction with the candidate. So at one time, a case came. It was a 40-year-old female with tummy pain. After anti-station, it was found that she had all the features of acromegaly. So she was having all the features of acromegaly. And also, he was having symptoms of polyuria, polydipsia, and constipation. So based on this, can anyone mention what? First, let me know what is the cause of tummy pain.
Hypercalcemia.
Yes. What is the cause of hypercalcemia here?
Main one.
Main one.
Hyperparathyroidism result. The total is main one.
Also gastroenterology syndrome.
Yes, but in gastroenterology it will lose motion. It is constipation. So this is a type of genetic disease. So any genetic disease in the PACES exam, whenever you are going to meet the concern, refer the patient to genetic counselor. Please keep these important things in mind. You can get a lot of genetic disease in the PACES exam, like the ATPKD, like the main one, like the main two. Whenever you are getting any genetic disease in the PACES exam, whenever you are meeting the concern, refer the patient to the genetic counselor. Wonderful diagnosis patient. So you can remember a rule, like any acromegaly patient. So this epigastric tummy pain is due to the hypercalcemia, due to the peptic ulcer disease. He is also going to have some melena. So in short, for PACES exam, you can remember this rule, that acromegaly with melena is main one. No doctor, no colon cancer. Acromegaly with fresh parectal bleeding. That is colon cancer. This is the particular reason I have mentioned this thing. So any acromegaly patient presenting with melena, this is main one. Keep this in mind. But if the same acromegaly patient comes with pararectal bleeding, that is fresh pararectal bleeding, bright red, then this is colon cancer. Sounds clear to all, doctor? Which one, Dr. Shabab? How? Pararectal bleeding. Okay, if anyone
Yeah,
is having.
acromegaly plus melena.
Yes. Why melena? Oh, okay. This melena is happening due to the bleeding from the stomach. Whenever
Zollinger-Ellison syndrome.
it can be due to Zollinger-Ellison syndrome, it can be due to the hypercalcemia itself. This hypercalcemia is causing peptic ulcer disease. Like our case here, this patient is having tummy pain due to the peptic ulcer disease induced by high calcium level in the blood. And whenever there is peptic ulcer disease, this is going to bleed. And any bleeding from the stomach can manifest as melena.
ভাই একটা কোশ্চেন ছিল যেটা হলো
Yes.
কনস্টিপেশন, ইউজুয়ালি তো কনস্টিপেশন থাকে না মেলানাতে।
না, ইউজুয়ালি থাকে না।
তাহলে তাহলে ওই ক্ষেত্রে কিভাবে বলবো?
In this case, yeah, we can avoid. But we can keep as Zollinger-Ellison syndrome as our DD. But if there is polyuria and polydipsia, then this is surely going to be hypercalcemia. Is it clear, doctor?
Yes.
Actually, constipation is not present whenever there is melena. But whenever there is hypercalcemia, the blood calcium level will bypass this condition. That right now the patient will present with constipation mostly. It will not create that typical loose motion type presentation that the melena will present. Because calcium has more power than the blood itself. That is why any hypercalcemia patient will present with constipation along with melena. Is it clear, doctor? Any confusion?
Yeah.
Okay. So let me go to the next scenario. This was a 28-year-old female. This is another real PACES case who came with tummy pain. After entering the station, she is complaining that she is having a recurrent episode of tummy pain. And in the family history, you have got a clue that her father was also having the same type of tummy pain who died of road traffic accident. So based on this information only, what differential diagnosis you will keep in your mind?
Family Mediterranean fever,
Wonderful.
hereditary angioedema,
Acute intermittent porphyria.
hereditary
Yes.
angioedema.
Yes. Anything else, doctor?
Acute intermittent porphyria.
Yes, acute intermittent porphyria, hereditary angioedema, and familial Mediterranean fever. But from your sense, can you remember any disease that can have some familiar predisposition also presenting tummy pain? Yes, Dr. Malik has given the right answer. It is the ADBAD. It will be first episode of tummy pain mostly. But with positive family history, these are the 4 causes of tummy pain anytime in the PACES exam. So whenever anyone tells that my father or mother also had tummy pain, just keep in mind these 4 differential diagnoses. That is familial Mediterranean fever, hereditary angioedema, acute intermittent porphyria, and autosomal dominant polycystic kidney disease. Is it clear to all, doctors? Okay, let me ask some type of difficult question. This is also a real PACES case. It was a 57-year-old lady has come with tummy pain. From outside, the blood pressure was given as 160 by 100. After entering the station, The patient is telling that she is feeling pain around the umbilicus. That is periumbilical tummy pain. And she has noticed that the pain increases 1 hour after eating.
Mesenteric ischemia.
Okay, doctor, let me complete the whole scenario. So 1 after our meal, the pain is increased. Also, she is having some loss of weight and appetite. Sorry, not appetite, loss of weight, because she is fear of eating. And in the past medical history, she has hepatitis B, and she had an episode of food drop.
Polyarteritis
Which is
nodosa.
Polyarteritis nodosa.
wonderful, wonderful, doctor. You have got the right diagnosis. It is a case of polyarteritis nodosa. Even before I complete the cases, it is a case of polyarteritis, and this is a real PACES case. This is a medium vessel vasculitis, which also affect the small vessels. Small vessels means vasa vasorum, that is blood vessels affecting the nerve, manifested at foot drop. It can be also given as wrist drop. This was a real PACES case.
So was
In
the
30
complete diagnosis mesenteric ischemia due to pain?
Yes, mesenteric ischemia due to pain. Wonderful, doctor. You have got the right diagnosis. Yeah, Dr. Osama has asked postprandial tummy pain cause, please. In case of postprandial tummy pain, if it happens right after the intake of food, this is peptic ulcer disease. For the PACES exam, it can be due to pancreatitis also. But if it happens 1 to 2 hours after taking meal, then this is something affecting the mesentery. That is mesenteric ischemia. Got your answer, Dr. Osama? Dr. Malik, did you get your answer? Okay. Just let me ask you one final scenario. Let me see. A 45-year-old male has also come with tummy pain. From outside, the blood calcium is given as 3.3. After ending the station, the patient is telling you that I'm feeling pain at the upper tummy, that is epigastric region, that is increased after taking food. And he's also having all the symptoms of hypercalcemia, starting from the head, that is low mood, then polyuria, polydipsia, tight motion, all of that stuffs. But in the past medical history, he keeps history of having bipolar mood disorder. In the drug history, he's taking lithium and ACE inhibitor. So based on this, first let me know what is the cause of tummy pain. Then what is the cause of the cause?
What is the location of the tummy pain?
Epigastric region, doctor.
Lithium-induced hypercalcemia.
Wonderful answer, doctor.
Nephrogenic diabetes insipidus.
No, doctor. The patient is presented with tummy pain. What is the cause of tummy pain here?
It can be peptic ulcer disease due to hypercalcemia,
Yes.
epigastric pain.
Yes, and hypercalcemia will also cause nephrogenic diabetes insipidus, resulting in the polydipsia and polyuria. You're right, doctor. Do you think you have to utter some safety netting for this patient from the given scenario?
Yes, AC inhibitor off করতে হবে.
Wonderful answer, doctor. Who has given the answer? Yes, we have to change this ACE inhibitor. We have to tell the patient, stop this medication, and I'm going to talk to my consultant to change this with safer one. Because lithium with ACE inhibitor can cause lithium toxicity. You can remember a mnemonic. The mnemonic is, sorry. You can just remember the mnemonic of lithium toxicity. The mnemonic is no abnormality detected. Here N goes for NSAIDs, the painkiller. A goes for ACE inhibitor. And D goes for dehydration, also diuretics. That I term no abnormality detected. So this patient is taking ACE inhibitor, and we have to tell the patient that stop this medication, because he can develop anytime lithium toxicity.
So the case was lithium-induced lithium toxicity causes.
No, it is not a case of lithium toxicity.
It is due to.
Whenever anyone is going to take lithium for a long period of time, this chronic lithium ingestion will change the calcium sensing receptor of the parathyroid gland. The parathyroid gland will sense that there is not enough calcium in the blood, so he will continue to release excessive parathyroid hormone, resulting in hypercalcemia. This is not due to lithium toxicity. This is chronic lithium ingestion.
Okay.
But he's taking ACE inhibitor, so we have to make him assured that stop this medication. In the PACES exam, also whenever you solve the part 1 and part 2 case scenario, you will see that for the UK, the GPs are the main culprit. I don't know for what reason they made the culprit. Here, the scenario is that the GP started the ACE inhibitor, and we have to make it correct.
I have a question. Does the patient need admission because lithium, there is chance of lithium toxicity?
Yes, doctor. We have to admit the patient. And there is another way to save your back in this case. Like sometimes in the PACES exam, you may be confused that whether you have to admit the patient or not. Thanks for asking this important question, Dr. First. Sometimes you may be confused that whether you have to admit the patient or not. You are confused that whether I would admit or not. You can save your back by uttering this line that I will keep you at the observation room and I'm going to talk to my consultant. In the meantime, he will come and see you, and I will tell you whether you need admission or not. So you are basically keeping the patient in observation room and calling him consultant. So you are again a safe doctor. You are not releasing the patient, not admitting the patient. You are in the middle ground, like stop driving till further assessment. Did you get it, doctor?
Please repeat.
Yes, doctor.
Repeat the sentence on time.
Okay. It is not for this case only. Sometimes you may be confused that whether you have to keep the patient admitted or whether you have to release the patient. You can keep the patient outpatient department. Whenever you feel confused, you just tell this line that I will keep you at the observation room and I will talk to my consultant. In the meantime, he will come and see you. And after that, I will be in a better position to tell whether you need admission or not. Write me the details line. So this is the line to save your back whenever you feel confused about admission or not. This is the same way of stop driving till further assessment. Whenever you are confused of stop the driving or not. Did you get your answer, doctor?
Yes.
Okay. So that's all for the first 5 prompt, that is a triple star prompt. And let me know from the doctors whether anyone is having any confusion or concern from this last triple star prompt of abdominal pain. After that, we'll have some prompt session. And Dr. Malik, the session is not completed yet. We are going to discuss some double star prompt and one star prompt. And we're going to come back to you with the epic mnemonic. I promise you. So it is clear. Can I proceed to the next prompt? Okay, let me proceed. Our next prompt is tight bowel or constipation. It's a double star prompt. So how to start? Taking the history. First, you have to ask, what do you mean by tight motion? How many times do you need to go to the toilet to pass motion? What is your user bowel habit? Then when you did start, is it the first time you are having this kind of problem? Then we can directly jump into the differential diagnosis. The mnemonic is can, die, hard. Here can goes for cancer, D goes for diet, I goes for IBS, E goes for endocrine, that is hypothyroidism, H goes for high calcium. For the PACES exam, high calcium are given in the perspective of hyperparathyroidism or sarcoidosis or metastasis or due to iatrogenic overdose, like medication, like taking calcium supplementation excessively. Then A goes for autonomic neuropathy, which is found in case of diabetic autonomic neuropathy and advanced case of Parkinson's disease. R goes for recurrent laxative use, and D goes for drugs. Here the mnemonic is OTC, that is over the counter. O goes for opioids, T goes for tricyclic antidepressant, which is an anticholinergic drug, and C goes for calcium channel blocker. So what will be the initial screening question for each of them? Let me discuss in brief. For cancer, again, the triple L, that is loss of weight, loss of appetite, lumps and bumps in the body. To rule out the diet, we have to ask, do you take enough fiber in your diet? To rule out the IBS, we have to ask, do you have any tummy pain that is improved after opening the bowel? Then to rule out the hypothyroidism, we just have to ask about the weather preference. To rule out the hypercalcemia, we have to ask the symptoms of hypercalcemia, starting from the low mood, then polyuria, polydipsia, then constipation is itself a given prompt. We can also add gravels passing through the urine. That is nephrolithiasis, which is a symptom of hypercalcemia. Yes, tummy pain is another. Sorry, I missed the tummy pain. Yes, tummy pain. So low mood, tummy pain, polyuria, polydipsia, and gravels passing through the urine. That is the symptoms of hypercalcemia. Then for the autonomic neuropathy, we have to depend on the past medical history of diabetes. Parkinson's disease is not given with the prompt of constipation, but in real life, you can get cases like this. Then R goes for recurrent laxative use. In the drug history, we have to ask about it, that do you use any bowel softening medication? Because there is a term called melanosis coli. Whenever anyone uses laxative recurrently, without taking laxative, he is going to develop constipation. We call it melanosis coli because whenever you are going to do the colonoscopy, you will get some pigmentation in the wall of the colon there. And the drug will be evident from the drug history. So this is all for tight bowel or constipation, that is can die hard. Let me know if any question is there from any of the doctors. If it is clear, then please give me a thumbs up reaction. Okay. And don't forget to upper theory. So this is for tight bowel. The next double star prompt is parectal bleeding. For parectal bleeding, again, for any case of bleeding through the rectum, we have to rule out hemorrhoid and anal fissure. So what are the initial questions of parectal bleeding? First, we have to confirm that this is a true case of parectal bleeding, that is hematochezia. It is not a case of melanoma. So we have to ask, what is the color of the blood? Is it bright red or dark color? Then we have to ask this question. This is the question to identify the location of the pathology. Okay, let me show you. Let me discuss with you. So this is our colon. This is the ascending colon. This is the transverse colon. This is the descending colon. This is the rectum. Descending colon. This is the sigmoid. This is the rectum and anal canal. So any pathology happening at the any pathology happening distal to the sigmoid colon. This is sigmoid colon. Okay, let me begin from the beginning. So any pathology happening in this way, in this colon, will present with parectal bleeding. But the bleeding that happens from the sigmoid and the rectum and the anal canal, there's a particular pattern of that bleeding. The pattern is that you will find, this is a feature matter, you'll find that the blood is covering the stool. It is not mixed with the stool. If the bleeding happens from the sigmoid colon or the rectum of the anal canal. But if it happens proximal to the sigmoid colon, that is the ascending colon or the transverse colon or the descending colon, at that time, the stool will get enough chance to interact with this blood. It will get mixed with blood. So whenever the patient is going to defecate, he will find that blood is mixed with the stool. And from the history, we have to rule it out. And I'm again repeating, if the blood covers the stool, then the bleeding is happening either from the sigmoid colon or the rectum or the anal canal, like the hemorrhoids or the anal fissure. But if the blood is mixed with the stool, then the bleeding is happening either from the ascending colon or the transverse colon or the descending colon. That is proximal to the sigmoid colon. So from the history, we have to ask this question that, sorry, where is this? Is the blood mixed with stool or it covers the surface of the stool? May I know if it is clear to all why blood is mixed with the stool or why it covers the stool? Okay. Then whenever there is any local bleeding, like the anal fissure or hemorrhage, the patient will find streak on the tissue. Whenever he is going to wipe his back passage, he will find some streak on the tissue. So we have to ask this to rule out the local pathology. Also, to rule out the hemorrhage, we have to ask this question. That is, anything coming through the back passage, through your back passage, and any blood dripping after stool. In case of hemorrhagic bleeding, the patient may sometimes feel something coming through the back passage and there will be dripping of blood after passing the stool. Then to rule out the anal fissure, we have to ask any pain while opening the bowel. Then, as usual, the question, what is the amount? Any bleeding for any other orifice? And do you think you are getting pale day by day? Do you feel dizzy standing from the sitting position? To rule out the hypovolemia. And these are the introductory questions for parectal bleeding. The differential diagnoses are either inflammatory bowel disease or malignancy or proctitis. And also you can keep the local causes like the anal fissure and hemorrhage, because you have to rule it out by doing the parectal examination. If you before doing the parectal examination or the digital rectal examination, you can rule out the anal fissure or hemorrhage. So you can keep them as differential diagnoses. To rule out the IBD, we have to ask the extraintestinal features of IBD. To rule out the malignancy, we have to ask that questions of triple L. And to rule out the proctitis, we have to depend on the past medical history and the casual contact history. Okay, let me ask you a question. This case has come at Diet 1 at UK Center. Patient was having parectal bleeding and he had a past medical history of prostate cancer, receiving radiotherapy. So what do you think? What is the cause of parectal bleeding in this patient?
Radiation colitis.
Yes, doctor. That is proctitis.
Can it be METS also?
Yes, METS does not present with parectal bleeding, doctor. METS present with bony pain. In the PACES exam, METS present with bony pain, is low back pain. METS will not cause parectal bleeding. This is due to proctitis. This case has come in this diet at the UK Center. And that's all for a parectal bleeding. Let me know for the doctors if anyone have any question or confusion from this. No question? Okay, if there is no question, let's proceed to the next prompt. It is one of the most big prompt, and I am myself unable to formulate any formula for this vomiting because anyone in the body, any pathology can present as vomiting. Like if anyone is having any brain tumor, this can present as vomiting. If anyone is having basal pneumonia, he can present as vomiting. If anyone is having peptic ulcer disease or GIT, also vomiting. If anyone is having liver pathology or kidney pathology, same vomiting. If anyone is having a GIT pathology, again it can present as vomiting. But for the last 4 years scenario, I have just identified particular differential diagnosis which comes mostly under the prompt of vomiting. They are mostly the adrenal insufficiency. In 70% of the cases, I have noticed that vomiting comes with the diagnosis of adrenal insufficiency. It can be due to sudden steroid withdrawal, or it can be due to the diagnosis of Addison's disease. Then it has come with the DD of pancreatitis, diabetic ketoacidosis, and any kidney pathology like AKI or AKI-CKD. Apart from these 4 causes, I have not personally found any other causes of vomiting. Dr. Malik, Addison's with TB. Actually, Addison's is autoimmune disease. Okay, let me tell you what this is. So you are going to, you want to mention the cause of adrenal insufficiency. So adrenal insufficiency can have multiple causes. It can have autoimmune cause. The autoimmune cause of adrenal insufficiency is called the Addison's disease. But adrenal insufficiency can happen without autoimmune cause. It can happen due to the sudden steroid withdrawal. Also, it can happen when due to adrenal tuberculosis or metastasis of malignancy. It can also happen due to histoplasmosis. So these are the way how the adrenal insufficiency can happen. Yes, Dr. HIV. Thank you for mentioning this. Yes, Dr. HIV. HIV is another TB. Thank you for mentioning this. I have just forgotten in this way. Yeah, these are the causes of adrenal insufficiency. And in the PACES exam, vomiting is given mostly on the background of adrenal insufficiency. They may give you a case that patient is a diagnosed case of bronchial asthma and she has been taking steroid for 3 months period, but suddenly she has stopped taking the medication, that is steroid. She is feeling better, that's why she thinks that she does not need it. And right now she has presented to you with the prompt of nausea and vomiting. So what are the initial questions for vomiting? The initial questions are, when did the problem start? How many times did you vomit? What was the content? Any food particles there? Then, is there any acid test, any bitter test? Acid test is to identify whether the content is from the stomach. Bitter test is to identify whether there is any contact from the small bowel also, like the duodenum. Then to rule out the volume hypovolemia, we have to ask, do you feel dizzy standing from the sitting position? Then you can directly jump into the differential diagnosis. I will suggest, again, go to the PDF, past medical history, drug history, and family history. For this vomiting prompt, right after analyzing symptom, you will get your diagnosis. Is it clear to all doctors? Any question from here? Yeah, Dr. Malik, what is the question? Yeah, vomiting due to actually these cases came in on the prompt of AKI on CKD. But this is very less likely to given. Mostly this adrenal insufficiency comes
Is it
in
due to the uremia?
Yeah, this is due to the uremia. Okay, let me give you a mnemonic to remember the features of Addison's disease. Yes, Dr. Malik. Do you have any other question, doctor? Yeah, AKI is due to vomiting due to AKI or AKI due to vomiting. This vomiting is due to the AKI. Yeah, both can happen, doctor. It is like whether egg is first or chicken is first. If you have multiple episodes of vomiting, that can cause hypovolemia resulting in AKI. And if you have AKI, that can result in uremia, that can also cause vomiting. So both way can be possible. So let me tell you the mnemonic to remember the features of Addison's disease. The mnemonic is double loss, double T, and double hypo. So what does double loss mean? Double loss means loss of weight and loss of appetite. In Addison's disease, the patient loses their weight and appetite, both. And double T means tanning of skin. In Addison's disease, the patient will have hyperpigmentation. Also, the patient will have tummy pain. And double hypo means hypotension and hypoglycemia. Whenever you suspect any adrenal insufficiency in the PACES exam, always start with examining the bedside blood sugar. Never forget to do this, doctor. If you suspect any adrenal insufficiency in the PACES exam, always start with bedside blood sugar measurement. So this is the rule: double loss, double T, double hypo, to remember the features of Addison's disease. And that's all for vomiting. May I know, can I proceed forward to the next prompt? Any question from here?
ভাইয়া আর কতক্ষণ হতে পারে ক্লাসটা?
At best 10 to 15 minutes.
Okay.
So the next prompt. So these are now one-step prompt. These are very less important. This has come at best 1 or 2 times. Our first step prompt is jaundice. So how to approach to a case of jaundice? We can analyze this jaundice. The prompt can be from outside. The patient has come with yellowish discoloration of the eye. Talk to him and examine him and meet his concern. So we have to analyze the yellowish discoloration based on the mnemonic of ODPAR. That is onset, duration, initial episode, progression, aggravating factor, relieving factor, and associated features. Then we can directly jump into the differential diagnosis. Jaundice in our body can present with multiple ways. This can be due to prehepatic cause, this can be due to hepatic cause, or post-hepatic cause. Regarding the prehepatic cause, it is mostly due to the hemolysis. But hemolytic anemia will never present to us with the prompt of jaundice. They will present us with the prompt of fatigue and pest. And in the PACES exam, never ever any prehepatic cause of jaundice will be given with the prompt of jaundice. We will given either hepatic cause or the post-hepatic cause. Regarding the hepatic cause, the causes that we have to keep in mind mostly are the hepatitis, that is hepatitis A, B, C, E, and also the Gilbert syndrome, that is a genetic disease. And in the post-hepatic cause, it is primary biliary cirrhosis or primary sclerosing cholangitis. So we have to take the travel history, transmission history, tattooing, and sexual contact in detail to rule out the hepatic cause. And to rule out the Gilbert syndrome, we have to ask, have you, whether this is the first time or this is happening multiple times? Because it is, if this jaundice is happening multiple times, that is, it comes and goes, then this is most likely Gilbert syndrome in the PACES exam. Like whenever the patient is having some stress, he is going to develop the jaundice. That is why we have to ask, is it the first time? And Gilbert syndrome is a cause of jaundice which comes and goes with the period of stress. And to rule out the hepatitis B, C, E, and A, we have to take the travel history, transmission history, tattooing, and sexual contact. Let's come to post-hepatic cause. In case of post-hepatic cause, the patient will have high colored urine, pale stool, also itching. If a primary biliary cirrhosis case is given in the PACES exam, after entering the station, you will find some xanthelasma over the patient's eye. This is the usual case. And in case of primary sclerosing cholangitis, can you guess any important past medical history?
Ulcerative colitis.
Yes, Dr. Ulcerative colitis. That is how the case can be given in the PACES exam. But never ever any prehepatic cause is given. An alcoholic patient is not given in the PACES exam with the prompt of jaundice. An acute intermittent, what is AIH? Autoimmune hemolytic. Dr. Malik, what do we mean by AIH?
Autoimmune hepatitis.
Oh, actually, Dr. Truly speaking, in the PACES exam, I have not seen up to now the autoimmune hepatitis case given. You can practice with some any mentor, but this case I have not found any time the autoimmune hepatitis case given in the PACES exam.
Any metabolic cause of the jaundice, like Wilson's hemochromatosis?
No, it is not given. Wilson disease comes in the PACES exam, usually with the prompt of tremor. Or you may be given with the prompt of abnormal movement, like chorea. Jaundice is never ever given. Up to now, it has not been given, and I hope it will not come. If jaundice comes, the examiner will assess whether you are ruling out the most common one, that is transmissibility. That's why travel history, transmission history, tattoo, and sexual contact is important. So may I know if it is clear to all about the jaundice approach? We are left with 2 prompts only. Would you proceed forward, doctor? Any question from anyone?
No, sir.
Okay. Let me drink some water. Okay. Our next prompt is liver function test abnormalities at routine blood test. This prompt is becoming popular in recent days due to the NASH. So from the outside, you may be given some blood test report, mostly the liver function test report. And from looking at the report, you have to keep in mind, you have to make inside your mind what should be the diagnosis. So in case of liver function test abnormalities, if the AST is more than ALT or the SGT-OT is more than SGBT, most likely it is alcohol-induced. But if it occurs reverse, like the ALT is more than AST or the SGPT is more than SGOT, then it is a case of non-alcoholic steatohepatitis. And this case has come in the PACES exam, and this is becoming popular day by day. This case has come 2 to 3 times. Then if the ALP or GGT is increased, then this is drug-induced, like the amoxicillin clavulanic acid or metoclopramide, or it can be due to heavy alcohol or oral contraceptive pill or primary biliary cirrhosis, or primary sclerosing cholangitis. Forget about this Wilson's and Hazel's. So these are the pattern of liver function test abnormalities given in the PACES exam. How to approach to this case? Whenever we are given any blood test report or any imaging report from outside, our first question should be, may I know why this test was done? Was it done during routine checkup or as a part of the evaluation of any of your symptoms? Like the patient is having some symptom, that's why that investigation was done. Or it was done during the routine checkup. Right after that, for this given prompt, my suggestion is complete the PDF SAGI and 5P if it is reproductive, and cover the GIT systemic question. You will get your diagnosis. For this prompt specifically, there is no screening question. Did every doctor get my point? This is how this prompt has to be approached. Is it clear to all doctors?
5P means?
Yeah, 5P means we have discussed in our interactive session. Okay, let me show it again. 5P means this 5P, pill, period, pregnancy, abortion or abortion, and partner. This 5P has to be asked for any female of reproductive age. Got it, doctor?
Yes.
Okay.
Sir,
Is it done?
the GIT systemic questionnaire, you shown
Yes.
it earlier or not, sir?
Okay, systemic question is there in the PDF. All the systemic question. These are the GIT systemic question. For every GIT prompt, after doing the symptom analysis, then PDF SAGIT, then I would suggest do the screening question for the differential diagnosis. Then at least touch the GIT systemic question. If you don't get to touch all the questions, it is okay. But at least touch all this GIT systemic question. That do you think getting pale day by day, any swallowing difficulty, any heartburn or chest burn, any tummy pain, any change in bowel habit, any change in color of the eyes, that is due to jaundice. This is true for every prompt. Whatever system prompt is given, touch that systemic question specifically. Like you may be given a case of musculoskeletal prompt, at least touch that systemic question. You may be given a case of neurological, at least touch all the systemic questions of CNS.
Yes.
Okay. So should I proceed to the next prompt? That is incidental liver mass on ultrasonography.
Yes, sir.
Okay. This prompt came 4 years back at Kolkata. So this is a one-step prompt. Before approaching to the question, it is almost the same way. We have to know what are the causes of incidental mass on ultrasonography. This can be primary hepatocellular carcinoma. This can be due to any metastasis that is secondary, due to colon malignancy or lung malignancy, anywhere. This can be due to hepatic adenoma, especially if the female is young and she is taking some oral contraceptive pill. These cases come one time in the PCS exam. Then it can be focal nodular hyperplasia, and hemangioma for young female also. It can be due to any liver cyst like ADPKD, hydatid cyst, or it can be hepatic angiosarcoma. You have to memorize the DD to tell it as the differential diagnosis of your incidental liver mass. You may be given from outside the prompt that during routine ultrasonography, a liver mass has been found for this patient. His name is Mr. Alexander or something like that. Talk to him, examine him, and it is concerned. So first, again, we had to ask why this ultrasonography was done to you. Was this done due to routine checkup or any symptoms? Then directly go to the past medical history, drug history, family history. You will get your diagnosis. Complete the history taking by Sajid and 5P. Then, for this prompt, ask the AAA history, because one of the DD is cancer here. This is hepatocellular carcinoma and also the metastasis. That is loss of weight, loss of appetite, lumps and bumps in the body. Then ask the GIT questionnaire. You will get your diagnosis for sure. Whenever the examiner is going to ask you what is your differential diagnosis, just mention these 8. You can mention this. If the patient is young and taking OCP, you can keep the hepatic adenoma as your first differential diagnosis. Also, for any young female, you can mention hepatic adenoma, focal nodular hyperplasia, and hemangioma. If the examiner wants to hear any other causes of liver mass, you can mention this. But whenever you are mentioning the investigation for this prompt, never forget, apart from basic, triple phase CT scan. Because this is the investigation by which you can differentiate benign from the malignant. Sounds clear to all the doctors? Can I proceed to the last from today?
Sir.
Yes, doctor. Any question?
Sir.
Do you have any question, doctor?
No, sir. No, sir.
Okay. So let's proceed to the last from today. This is the last one step from. This is an incidental mass found at adrenal gland on imaging. This case has come only one time at the UK center. So again, before approaching to this case, just let me discuss simple pathology. The adrenal mass can be of two types. It can be benign or it can be malignant. In case of benign, it can be metabolically silent or it can be metabolically active. So what are the causes of benign adrenal pathology? If you look at the structure of the anatomy of the adrenal gland, it is divided into two parts. One is cortex, another one is medulla. Again, the cortex is divided into three parts. From outside to inside, we can remember the mnemonic, that is GFR. That is zona glomerulosa, zona fasciculata, and zona reticularis. From zona glomerulosa, aldosterone secretion happens mainly. Whenever aldosterone secretion happens excessively, we can have Conn syndrome. From zona fasciculata, glucocorticoid is secreted mainly. Whenever it is secreted excessively, we can have Cushing syndrome. From zona reticularis, androgen is secreted. It is a very rare pathology where excessive androgen secretion occurs, but if it occurs, then we can have some excessive body hair or pubic hair or some ambiguous genitalia. It's very rare pathology. And it will never be given in the PACES exam, for sure. Then come to the medulla. From the medulla, mainly the catecholamine gets released. Whenever catecholamine is released excessively, it is the disease called pheochromocytoma. So these are the pathology that can affect according to each layer. On top of that, the diseases that can affect the adrenal gland are the malignancy that are primary or secondary, or it can be affected by the TB, HIV, or histoplasmosis. So let's start how to take history. Again, we have to ask why the test was done for any symptoms or during any pathology or during routine testing. Then for this prompt, we can jump into the differential diagnosis. One prompt is one of the differential diagnoses, Conn syndrome. In Conn syndrome, patient has hypertension. Along with that, so what happens in case of Conn syndrome? Due to the excessive aldosterone, patient will develop hypokalemia. Because the aldosterone will cause excessive sodium reabsorption from the renal tubule and potassium loss through the urine. So it will cause hypokalemia. This hypokalemia will cause myalgia. Patient will tell you that I'm feeling some muscle cramp at the back of the leg. This hypokalemia will cause weakness of the limb, the hands and feet. Also, this hypokalemia can cause nephrogenic diabetes insipidus, resulting in polyuria. So to rule out Conn syndrome, we can ask, do you feel any pain at the back of leg? Any muscle cramp at the back of leg? And then any weakness at any parts of your leg? You can just ask these two symptoms to rule out Conn syndrome. To rule out the Cushing syndrome, we have to ask about the weight gain, because we'll discuss in detail the approach to weight gain in our endocrine problem. In any case of Cushing disease, patient will have weight gain, and this weight gain will happen mostly at the central part of the body. To rule out pheochromocytoma, we have to ask, have you ever felt sudden racing pacing of heart with sweating? There is sudden palpitation with sweating, and patient will feel some flushing like sensation. To rule out a malignancy, whether it is primary, which is very much rare, or secondary due to metastasis, we just have to ask the question of triple L. Then to rule out a TB, HIV, and histoplasmosis, we have to take the travel history and casual contact history. And that's all. But never forget to take help from the past medical history, drug history, and family history. May I know, is it clear to all the doctors? Any question from this prompt of incidental liver mass? Sorry, renal adrenal mass? Okay. Can I expect any question from any of the doctors regarding any of the prompts discussed today? So we are about to end our session. Yes, so drug history means, yeah, for every prompt we have to complete the PDF Sajid. That is past medical history, drug history, and family history. We have to ask them according, doctor.
May I ask a question?
You, doctor.
So, which drug can cause obstructive jaundice? Like,
Okay. Amoxicillin clavulanic acid.
okay.
And also metoclopramide. Thank you for asking the question, doctor. Any other question from any doctors?
Doctor, this session is recorded?
Yes, doctor. Oh, yes, doctor, it is recorded. Sorry, Dr. Malik, I have to get back to EPICS mnemonic. Okay, this is the EPIC. Here, E goes for esophageal ring or eosinophilic esophagitis. P goes for pressure from outside and pharyngeal pouch. This pressure from outside is most likely due to the malignancy affecting the lung, or it is due to the lymph node swelling. That is also due to some malignancy nearby. This lymph node is going to compress from outside. Then I goes for infection. This is mostly due to esophagitis. This esophagitis can be due to infection or it can be due to bisphosphonate. It can be due to cancer, or C goes for cancer, or S goes for stricture. Stricture due to long-term chart or to previous history of radiotherapy or history of caustic ingestion. Did you get your answer, Dr. Malik? Okay, Dr. Malik. ASD. ASD goes for, A goes for achalasia, S goes for systemic sclerosis, and D goes for diffuse esophageal spasm. Any other way, doctor, I can help you?
Can I ask a question?
Sure, doctor.
I had a case of scleroderma once, and in one of my exams, and it said that the patient had dysphagia, and the patient had change in voice, hoarseness of voice. So when I was giving when I was taking the history, or when I was giving the differentials, I said that the scleroderma could be associated with the esophageal stricture, and the stricture could lead to recurrent laryngeal nerve, could be malignant, and that mediastinal mass could lead to recurrent laryngeal nerve palsy. So I just want to know whether that is the correct thought process or not, and whether you would want something like that to be stated in PACES. Are the examiners expecting something like that from us?
Actually, in our endocrine session, sorry, not in endocrine, in respiratory session, we'll discuss the approach to the hoarseness of voice. This hoarseness of voice mostly due to the recurrent aspiration that is affecting the larynx. But the voice change, that is nasal voice, will happen in case of oropharyngeal dysphagia. Systemic sclerosis patient will not have that nasal voice. He can have hoarseness of voice due to the aspiration, recurrent aspiration.
Right, right.
Did you get your answer, doctor, or have I been able to provide the right answer? If you any confusion left, please repeat your answer, doctor. Repeat your question.
No, that's fine. That's fine. I'm just talking about the approach, and I will try to make it more systematic. I think that's where I want to be. That's what I need to do, isn't it? Make my approach more systematic and more
Yeah, doctor.
straightforward. Right?
In our hoarseness of voice approach, you will get a separate name. It is called high dog. The dog is going to bed you, and there easily you can rule out the malignancy and all things like that. And to rule out any malignancy, you have to ask the question of triple N. That is loss of weight, loss of appetite, lumps and bumps in the body.
Thank you. Thank you.
Okay, most welcome, doctor. And don't forget to do the homework. May I know, is there any question or confusion from any of the doctors? I think there is no confusion left. I have again posted the link of the group of this course. So if anyone is interested to join the course, he can directly message to my inbox, or this recording is going to be free. It is going to be uploaded separately for the active candidate and the Telegram channel. And also this is going to be uploaded at the YouTube channel also. So right after this, the candidate, you will get some access to cases, and you will get 2 to 3 days to take preparation for all the cases and all the approach. Right after that, you have to start practicing with each other. And within 2 days, I will send personally to each of the active candidate this PDF. You will get it. So start the preparation. Also, I will send a separate channel to it. Dr. Telegram channel is for the registered candidate. There the recording will be uploaded, all the recording. And this is actually free session. There are total 10 sessions. For every course, 1 or 2 sessions are given free. And that is uploaded in the YouTube channel. And I actually suggest everyone not to repeat this course, because I have tried my level best to formulate all the things in one course. So I discourage anyone repeating this course, because every time you're going to get the same things again and again. Just you have to practice whatever things you are going to get from this course. And that's all. So again, good night, doctors, and see you later with this prompt. Good night.
Thank you, Bhaiya. You are one of the best mentor of SCC I have ever met.
Thank you.
Thank you.
You are most welcome. Take care, doctors, and do practice. See you